Good evening, everyone. And today we are into the day two of a deep dive into advances in breast cancer, and we are doing the updates from ESMO and San Antonio Annual Meet 2025. And we had a great day one where we discussed on in the early setting all the three subtypes and the great lecture on how to read and interpret Kaplan-Meier curves by Dr. Sandel. So today, without wasting much of a time, our first panel discussion will be done by Dr. Vamsi, and he'll have the panelist Dr. Nikhil, who is a senior medical oncologist from Apollo Hyderabad. We have Somyo, who is from Hyderabad, who's from Bhubaneswar, and we have Nilesh, a dear friend from Mumbai, as again a senior medical oncologist of Coimbatore, Dr. Bharat Rangarajan. I think he has joined. So he has four panelists, and Dr. Vamsi, your topic is metastatic hormone positive breast cancer, and you will have 35 minutes to do the panel.
Thank you so much. Thank you so much, Dr. Sahu. And Bharat, Dr. Bharat, are you there? Not seeing you.
Sir is joining in two
Sir is
minutes. So you
joining.
can start.
Perfect.
He'll joining. Yeah.
So anybody who doesn't like the first questions I ask can blame Dr. Bharat because he was not there. Right. So I have a great panel, Dr. Soumya, Dr. Nikhil, Dr. Nilesh, and Dr. Bharat. So let's jump straight in and let me start with Dr. Nikhil because I see his face first. So Dr. Nikhil, first line metastatic breast cancer, HR positive, what's the treatment of choice for you?
So I think this particular question's answer has been settled with the Mona Lisa as well as Monarch 3. I think either choice is fine with me, but my go-to choice mostly is ribociclib. That is what I do in practice.
That's fine. So a CDK4/6 plus a ET, that's the standard choice for you. I think
Correct.
that's what I was looking for. And the
Yeah.
PFS data trial I have shown you, it's interesting that all the three studies actually had a kind of similar hazard ratio of around 0.57, 0.58. The OS was seen with the Mona Lisa. Hazard ratio is 0.76. So, in terms of when we look at say EGFR or something, it's probably lower than that. But then in a breast cancer, which is ER positive, HR positive, this is still acceptable. Dr. Soumya, first line remains some CDK4 inhibitor. Let's not go into the details, but a CDK4/6 plus a ET. Is that acceptable to everyone?
Yeah, so any of the CDK4/6 plus ET, we have got the data for OS for Malaysia, and for the Monarch and the Malaysia, but the Paloma 2 is not there. But then it is affordable for many patients. So yes,
That's fine. So that, like I said, the consensus is that we will use it. So like they say, the consensus for first line remains AI plus a CDK, AI or something based on what previous ET they have used. So yes, the god of cricket is still Sachin Tendulkar. I think there can be no doubt about it. Same way, no doubt, first line remains an AI plus a CDK4. So let's make things interesting. Now, what if when a patient progresses or when at baseline, would you do any NGS? What are the investigations you would like to do? Can I ask Dr. Bharat if he has joined?
Yes, Vamshi, I have joined.
Yeah,
In general, I don't prefer to do an NGS and breast cancer, and I
perfect.
don't do it also.
Very good.
I would like to look at PIK3CA either at that time or if there is an old block available on an old block
Okay.
and an ESR1 mutation. But
Okay.
having said that, now with all this data coming in and the price cost being, sort of coming down on NGS, instead of looking at just ESR1 and PIK3CA, it might be, like one of my consultants told long back, throw the Harrison at the patient. Now, we tend to throw the NGS at the patient. We don't know anything. We'll just throw the, NGS and maybe the Harrison also at the patient.
Sure. Dr. Nilesh, now this is for me still a debatable question. Reason being that doing an NGS at baseline, you would miss the ESR1, which is not a truncal mutation. ESR1 is a resistance mutation. PIK3 can be picked up at baseline or later. Would that impact your treatment if you do the PIK3 at baseline? I know I'm a very conservative person doing this heresy of saying let's not do an NGS at baseline. I'm going as a heretic, but do you think it is warranted to do it at baseline or it's okay to do it later? Would an NGS at baseline impact your first line treatment? Dr.
So
Nile.
as of today, short of a BRCA mutation, nothing will impact your first line treatment. But we see that now there's so much data coming on about the other generation PIK3CA inhibitors also. And PIK3CA is not necessarily an evolving mutation. So I see no harm in doing it upfront just to be well informed, because while it not be a predictive marker, it is possibly a prognostic marker, in the sense that we know that these patients who are PIK3CA mutated have a more resistant disease and generally tend to have a more aggressive.
Like a prognostic.
Yeah.
Prognostic. Very good. Dr. Soumya, BRCA, Sir Bot, so let me just get that out of the way. In a HR positive, would BRCA influence your first line therapy at all, or is it for down the line that you would like to reserve your talaparib or talazoparib or your olaparib?
Yeah, so mostly it will be the if BRCA is there, then probably I would expose it a little bit down the line, but I'll make sure that the patient is exposed to that. Regarding NGS PIK3CA is a must for me at the baseline, and IHC HER2 1 plus and 2 plus, the low part I will make sure that it is done.
Okay, so again, the PIK3, would it impact your treatment, or would it just be a prognostic marker for you at baseline?
As of now, it is prognostic, but it gives me a little bit more comfort zone to consider options.
Very good. Dr. Nikhil, agree with all this? What's your take on the peak P10 AKT? Would you like to do it earlier? Would you like to do it later? How do you go about it?
So PIK3CA is a more of a truncal or clonal mutation, as you have mentioned, and that would remain as it is all throughout the patient's treatment management. Unlike ESR, sometimes which comes under the pressure of AI. So sometimes you may not have ESR initially, but eventually it can come being a subclonal mutation. Now, at the baseline, as rightly pointed by all my colleagues, that I think we may not do NGS. We are currently not doing NGS for most of the patients, but I think we need to probably eventually change our stance over a period of time. We need to look into PIK3CA more and more. We have got trials in that regard. I'm sure, I think you will show those trials also, that it's not only prognostic, but also is now predictive for first line for all of us.
Okay.
In terms of management, at least in terms of data, in terms of the outcomes, because PIK3s are absolutely poor prognosis patients. You
Okay.
need to have slight better drugs, and that is what we are looking at. BRCA for second line, I think I will be looking at in terms of treatment management, but BRCA is something which I would do for almost all the patients.
All right. For all HR positive, would you be doing BRCA? I mean, I don't typically do it. So I do it only
I
in
do
that
it. I
subset of
do.
younger or with family.
The possibility is quite low, but that is what we do for all patients,
All right.
for also for familial screening also.
All right, fair enough. I mean, I'm just putting it out there. Again, I think Dr. Sahu has chosen a very conservative group of panelists who don't jump the gun for NGS at the same time. But like Dr. Nikhil says, all of us are slowly evolving. A reason, especially for ESR1, because the whole hype right now is for SERDs. And ESR1 is not found at mutation at baseline in less than 1%. It usually starts later, so that's how it would affect. So the other question is, okay, you have done the NGS at baseline. Dr. Bharat, would you still use the CDK, or would you have a different plan of management?
If you have done prior to using
Yes, prior. At
first line, yes.
baseline, you have done, you found a PIK3. Would it change your management,
No,
or would
no.
you still go with the CDK?
I would not change the management I would still go ahead. But of late, I found a patient who NGS. I don't do NGS at baseline, but I found a patient with T1C N0, P T1C N0 patient, elderly woman whom I would have just closed my mind, not even done an oncotype DX and done a aromatase inhibitor as adjuvant. For whatever reason, the surgeon who operated, I think, mistook oncotype DX and NGS and sent an NGS, and there is an ESR1 mutation.
Okay.
So the problem is, you do these mutations. Now
Okay.
I started AI saying that you are 77, you don't need oncotype DX. But anyhow, they had sent. He said the oncotype DX will come, and finally when I saw it's so I don't think that doing an NGS is a solution. If you find an ESR1 mutation, so PIK3, your question, PIK3 is not going to change. But what if you do and find an ESR1 mutation in a metastatic breast cancer patients upfront? Then what you do, because there is where you are going to sort of get confused.
Fair enough. So again, the reason I put it is because there was a paper regarding the PIK3 and ESR1. This was on the Monarch 2 of the EBIMA and fulvestrant, and what they showed is that irrespective of whether there was a PIK3 wild type or mutant, the Abema plus fulvestrant did better than the comparator arm. Remember, this is a comparator arm. You do not compare it to a PIK3 inhibitor, but you compared it to the uh, other arm, and you found out that both in terms of the PS and the PFS and the OS, the Abema plus the fulvestrant still worked. So it's not to say that it doesn't work. When they looked at the ESR mutant and ESR wild type, again the Abema worked, though the OS was not met. Now, OS in this scenario can mean many things. So at least you have some data to say that you can use the same drugs. So that brings us to decision of treatment after progression. So assume at this point you throw the sink, the NGS sink, and then what all would you be looking at? Dr. Nikhil, what are the characteristics, patient as well as the NGS that you would be looking at for deciding your treatment?
So patient-related characters will definitely mean the volume of disease, the performance status, etc. What we should be looking at. What is the time of progression from the previous treatment time points also is something which is very important to us. What is the tempo of the disease? In terms of the genomics, which we'll all be very much interested in these patients, which we'll definitely would like to see the ESR1, which is quite commonly seen after the first line these days. And the more and more we start doing it, the more and more we are going to actually see those patients. Not only that, as we discussed about PIK3CA, PIK3CA and AKT, other mutations, and BRCA for sure, we need to look into BRCA over here for sure. So these are the common mutations what one should be looking at for now.
Okay, Dr. Nikhil, liquid biopsy or would you insist on a tissue? For PIK3, we do know that there is some variation, but ESR, they say that liquid is probably better. So are you comfortable with the liquid biopsy or would you insist on a solid also? Or do both, as some people do?
I think only liquid biopsy for now. I think that has been
Very good.
proven beyond doubt that it, in fact, it gives you a better, I would say, variability is better picked up on a liquid than a solid.
Excellent. So Dr. Nilesh, agree with that?
I agree that if I'm looking at an NGS, especially PIK3CA and an ESR1 mutation, the ctDNA is preferable. I would sometimes do a biopsy if I doubt whether this is a change in the IHC
No,
marker.
that's different. That's different. You would like for the IHC agreed, but for this reason I was asking. Perfect. So I think everybody agrees that you would do a test. Which test and how many genes? I think we are beyond that discussion. You would essentially do a test which covers all of these. I think that let's leave it there rather than 30, 50, 500 gene discussion. That discussion is really not worth it. So this is essentially how we look at it. You have a HR positive in adjuvant. Patient is receiving CDK because remember now a lot of our patients who are high risk, who are likely to relapse will receive your adjuvant CDK. So those patients who are on adjuvant CDK and relapse within the first 2 years on CDK would be your primary endocrine resistant. Those who have completed the endocrine therapy and then relapse would be what we call a secondary endocrine resistant. Whereas in a metastatic setting, if you relapse within 1 year, then 1 or 2 years, that's when you would call it a primary endocrine. If you relapse later, that's a secondary endocrine resistance. So again, you start splitting hairs and start splitting your mutations to decide how you're going to go about it. So this year we had one paper that was the, okay, I missed a slide somewhere. All right. The uh, SABS this year had around 3 to 4 good and interesting papers on this sort of situation, which was the secondary and the primary endocrine resistance. One of the biggest trials was the EMBER-3. Now, I'll just show the slides in 2 minutes quickly, and then we'll talk to the panelists about their opinion. So, imlunestrant is an oral selective estrogen receptor degrader. That's a SERD. They combined it with mono and with abemaciclib. So the design was that they used a monotherapy versus standard of care, which could be either fulvestrant or exemestane. The recurrence should have been within 12 months of completion of AI. So the if it was adjuvant or progression on first line. So essentially, this is a resistant kind of a endocrine resistance. So in that, they did allow prior CDK inhibitor. Now, when this post-monarch data came out, they added an arm of abemaciclib. Now, this is important. The C arm is actually a kind of a post hoc analysis. Not post hoc, but a protocol amendment, which was done midway. Therefore, the original endpoints are A versus B, C versus A, and A versus B in all patients. So again, remember you're testing IMLU versus standard of care for ESR1 mutant and in all the patients. but you're only testing the IMLU and EBIMA versus IMLU. You are not doing this versus this. So again, the standard discussion that we have, what does each component bring into the discussion? We still are not very sure, but that's what this arm tried to look at, the IMLU plus EBIMA versus the IMLU alone. The important thing to remember is how many patients got prior CDK4, that was around 59%. ESR mutation is around 40 to 30%. Pretty much well balanced across arms. 32 here, 36 here, and 42. Generally well balanced, and prior CDK around 59 patients. Endocrine resistance is a secondary endocrine resistance in around 90% of the patients. This is the result when you look at the PFS, and the PFS is 5.5 versus 3.8 for IMLU. When you look at in all the patients, it's around 5.6 versus 5.5. So, Dr. Bharat, straight off, a lot of noise on EMBER, and your benefit in PFS is 1.6 months. Satisfied?
See, this is ESR1 mutation. This is in the ESR1 mutation patients.
Correct.
Let's leave out the non-mutated patients. They're not
Correct.
doing
That's
well
the
anyway.
all patients, because in
All
the
patients are not doing well. See, ESR1 mutation patients are not going to do well anyway. Although this IMLO is supposed to be active in the ESR1 population. But secondary endocrine resistance, after 59% of patients have already received a CDK4/6 inhibitor, is a very high risk disease. So we cannot expect more than this much of a magnitude of benefit in this. So this is not surprising. But the importance is that we can put the patients for one more line of non-chemo agent. That is why this is interesting. Not because, the results are great. You're pushing away the chemotherapy. That's what we always want to do in an endocrine patient.
So, Dr. Bharat, being a devil's advocate, you would anyway do that. You would still give them a second line of endocrine. You're just saying that by adding a new fancy drug called IMLU, you're increasing it by 1.5 months.
Yes,
That's
true.
the
The only thing is you are getting a little bit more time off chemotherapy. So time to chemotherapy prolongs. That's important in endocrine patients.
I will come back to that point. Dr. Nikhil, see this graph. First 60% almost is dropping in the first 5 months. You have a 60% drop, and that's when your numbers slowly start changing. And look at the numbers down. There's a lot of censoring going on. It is there, but how impressed are you with this data, Dr. Nikhil?
So yes, so initially you are going to have some rapid progressors. There is no doubt about it, irrespective of the arms you are on. But it also tells you a story that those who probably had responded would probably continue to respond for a bit longer time. And that is where I believe the real benefit of this particular drug seems to be. So I think it is, if you don't respond, then you are already done. But if you respond, there's a good possibility. In fact, there was an updated analysis which does tell you that the OS, I think, is touching around 14 months or something.
I will come to the OS again.
Yes, something like that. So I think it only for the responders. So that is where we stand. So there are a subset of patients. Again, to my mind, whether a single agent is enough for such difficult, or should we go for a combination? I think that needs to be really discussed in the forum.
So, Dr. Nilesh, this is exactly what my cutout is. Because the IMLU plus EBIMA, when you compare it to IMLU alone, you had a 9.4 months versus 5.5. Remember, this is against IMLU. And your normal SOC is only 3.8. So 3.8 to 9.4, that's a bit more respectable. So Dr. Nilesh, your thought on this full West IMLU plus EBIMA subgroup rather than only the IMLU subgroup. Is this a better option? You're not finding that rapid fall here. It's only 20% fall. So, probably your EBIMA addition is adding something there.
Correct. But then this is a group of patients which are not exclusively ESR1 mutated. So you already chosen a better group of patients, right? This is
all comers, and
all
I will
comers.
also
This is
show
all
you
comers.
Yes, that was all comers, what I showed you now. And this is the ESR1 status mutation. Even in those whom it was detected, the subgroup analysis was 0.53, which is as good as non-detected.
Correct. So the combination of illuminastrant with abemaciclib seems to be doing better, and the quantum of benefit also seems to be better.
Perfect. That's exactly what I also would have thought. The idea is this, when you have a subgroup analysis, this was a subgroup analysis where they looked at IMLU versus IMLU in others, and they also looked at PIK3 mutations, and again found that if you had a combination, that was doing better than the monotherapy. So, all this.
A small thing.
Yes.
just observation. If you look at all trials across with a single agent ESR1 inhibitor,
Yes.
you will
Yes.
find that similar curve.
Absolutely.
And
Dr.
in such
Sahu, you have
things,
seen my slides. You're not allowed to comment on this. That
no,
was
no,
what I
no,
was coming to later.
not this one. I was coming differently. So PFS
Yes.
is not going to be a good point how we should be looking at this data set of that difference. That's what I wanted to tell you.
Perfect. So
And if you add a three drug combination or something, that fall is going to be smaller,
very
smaller.
good. So, Dr. Soumya, do you agree with that statement that PFS should not be the only endpoint? So, do you agree with that statement, first of all?
No, I don't agree to that point, but I do agree that monotherapy oral SERD is going to go away. So
Okay.
mostly because of the initial fall. So the 40%
Okay.
fall is there. So probably we'll be looking into something like patients who have not been
Combination.
exposed. So oral SERD plus abemaciclib or oral SERD plus everolimus. So these things are going to come up definitely.
Perfect. So again, the problem is the conclusion of the author says that IMLU as a monotherapy is providing PFS in ESR1, whereas the IMLU plus ABEMA is performing in all benefits. So you could give it as mono, you could give it as this. So Dr. Nikhil, where exactly would you place a monotherapy now? Because like Soumya is saying, you don't have the fall, so better to give a combination. But then the whole concept of a SERD giving for a monotherapy, is it really going away? What's your thought on that?
So again, if the patient has got like a low volume disease, slightly older patient, it's more to do with the patient-centric, I would say, approach over here, where probably I would probably end up giving LC because I will be more concerned with toxicity. These are the
Right.
only areas probably in long term I would think about using a single
Perfect.
agent. Otherwise, as Soma just now mentioned, I think probably we will be looking at more deeper responses and outcomes with the combination. So these
Okay.
are the areas I think probably we are moving towards the combination in the
Okay. Dr. Tarun, can you look into it? Somebody is not able to see the slides. I guess it's being seen by everybody else, so somebody is having a difficulty. So, Dr. Bharat, my question is it now matter whether you test ESR1 if you're having IMLU plus ABEMA? Because that works in all patients. It works in ESR1 patients. It works in prior CDK4 inhibitors. Does it matter? Now that I have shown you
Um,
this,
no, see,
you
this
still
is
matters.
asking the reverse question. Uh,
It
uh,
matters.
it matters, at least we should know what is
Okay,
happening in
correct.
that patient.
Right.
But
So,
as everyone said, it would be yeah, second line hormone SERD, whether it's injectable, the our fulvestrant, or whether it's an oral new one, which we don't have. But along, like Swami Surat Panda said, along with the second agent.
very
And when
good.
we are giving that second agent, we may sort of play around knowing whether there is PIK3CA, knowing whether there is an ESR1 mutation. We may play
Okay,
around for the second agent, whether it's an
very good.
everolimus, whether it's an alpelisib, capivasertib. So we may want to know what the other
So,
mutation is.
Dr.
So
Bharat,
we
my
need to
question
know.
now is to you is what Dr. Sahu was saying that PFS is not what we are going to look at. We are going to look at longer things. So, what do you want from this trial? Do you want an OS? Only then will you be convinced, or are you satisfied? Like Soumya says, no, even PFS matters in this situation.
Um, See, this question always this debate of OSPFS. This is
OS, yes,
I don't know, a never-ending debate. But
sure.
when we are talking about endocrine agent,
Okay,
I think a PFS and time to chemotherapy, they are all important endpoints for
all right,
patients.
fine,
Hard endpoints of OS, we all love it. But to wait for that is
all right,
then we'll be
very good.
denying
So,
so many our patients many things.
the wait is over, Dr. Bharat. This is the
Mhm.
Annals of Oncology updated analysis presented 5 days back. 15 December was the publication. So I thank Dr. Akhil from Kerala because he actually posted in a group and I saw that I have a meeting after 2 days on it. So it was posted on 15 December and it's very interesting because this shows increased time to chemotherapy. It
Exactly.
shows increased chemotherapy free survival, which are
Hmm.
all endpoints which are fancy. But then when you look at the OS, there is no difference in the OS when you're looking at IMLU versus the standard of care. If you're looking at IMLU ABEMA versus IMLU, there is no benefit in either the ESR1 group or without the ESR1. So essentially, this trial does not have a OS benefit. And remember, the original data analysis was actually a negative trial because the statistical significance, it's good to go back and read. They wanted three endpoints, only two were met. So the statistics became diluted and the actual endpoint did not end up being significant. It was 0.03, but it was not significant. So by statistics, This is actually a negative study.
Negative
When we look at the A's, you spoke of A's. When you have a combination, discontinuation is 9% here, only 1% with the standard of care. So not very bad, but still not very good either. You do have grade 3 toxicities in this study. So again, is this a positive study? Is it one of those where you have clinical significance? Because, like Soumya said, even a time to chemotherapy or time to chemotherapy free interval is still nice. Statistics, well, not very important. Soumya, what do you think?
So if we look at the OS cutoff, it was 0.61. The difference was around 10 months. So it was something like 35 versus 23 or something like that.
Correct.
The only thing is that if we take out the ESR1 mutant without the PIK3CA mutation, then the hazard ratio becomes 0.42 and the cutoff was 0.4. So something like this, hazard ratio less than 0.4 was taken as significant.
Correct.
Statistically, if we look, the data was not significant in the even in the mutated ESR1, 10 months difference numerically, but hazard ratio was 0.6. The cutoff for the statistics was 0.4. So I think that still 10 months is a
Clinically still something relevant.
Yeah.
So again, I was thinking of that, but now I don't feel so bad if I am not able to procure immunosupressant at some absurd price from the US, because the benefit that we are getting is there, but frankly, I don't feel so bad now if I can't get it for my patient. Now, this is the second study. We have the Evera study. This is the giredestrant. Now, the giredestrant is a slightly different modality. It has again estrogen selector receptor antagonist and degrader. So we are getting all these new things coming in. Now, Jira was used along with everolimus. Fairly simple study. Now, I like this study because what they specifically said is patients should have received CDK4/6 inhibitor, and they could have ESR1 or not. Very simple study. Very rare to see a simple study. Everolimus plus giredestrant versus standard of care plus everolimus. Now you see the endpoint, and this kind of an endpoint, you're having 10 months versus 5.5 months, which is somewhat what you see with the earlier study. So you have ET with around 3 months. You add imlunestrant, you got 5.5 months. You add everolimus, you're having 5.5 months. But when you add the other one, giredestrant, you're actually increasing it to 9.99. When you have a co-primary endpoint of PFS in the ITT population, again, 8.7 versus 5.5, which is good. When you're looking at the interim OS, it does seem to be trending to that positivity, though again,
It's
small
immature.
numbers, no maturity, etc., etc., etc. But still showing some trend to it. So Evera seems to be a decent drug in that sense. They do have side effects, though no major grade 3, grade 4 of the selected ones. It doesn't mean nothing. It just means selected ones they did not have. So they concluded that giredestrant with everolimus seems to be a better drug. The benefit is there in the ESR1 mutant population, 0.38, and in the other one. So, Dr. Nilesh, what do you think now? So should we go jump with the previous trial kind of a Imlut kind of a presentation, or with the Jira presentation, Jira plus Evro?
So by and large, both the studies had similar set of patients. Um, in There's no doubt that the PFS values in this study, especially in the ESR1 mutated as well as in the ITT population, seems to be a lot more significant with a better hazard ratio. So if you were to compare the two studies, I would think that a median PFS of somewhere around 9.5 months is definitely an improvement.
Perfect. So I agree with you. So this is still a study which actually looked better to me, and it does have, if we get the OS, I think this is one place which seems to be doing well. For me, this is one of the SERDs which does well. But again, if you have to import the drug, the quantum of benefit that you're getting, I'm not sure it is really worth. The next question, are all oral SERDs the same? Remember, we had the elacestrant. Now, elacestrant came in a big way. You had 400 mg versus investigator choice. Now, prior CDK was allowed, prior ET was allowed, standard of care was ET, and look at this drop. 60%. It's like falling off a cliff. The first testing you do and you fall off the cliff here. This is in elacestrant PFS. This is with ESR, this without ESR mutation. This is with ESR mutations. And the PFS is actually 3.8 versus 1.9 months. That's the PFS. So elacestrant, there are a lot of fans, all our groups, whenever we have a discussion, and then that 5 people saying do ESR1 and give elacestrant for a PFS advantage of 1.5 months. The only thing which they give is the 6-month PFS, which sounds nicer. So again, Dr. Bharat, do you ascribe to Dr. Sahu's view that, KM curves are not the only thing we should look at. 50% may drop out, but then you're getting that slight difference. Is elastic strength worth it?
This is a loaded question.
Yeah.
Strength is worth it if this for this magnitude of PFS. Is it worth it against the standard of care? That depends on the cost also.
Yes.
Toxicities are not going to really matter much because we are using the same SERD, or everolimus has got more toxicity if you're going to use it in second line. So that's not the question. The question is, whether it's financially worth it to do that. In this
Correct.
situation, it may not be financially worth it. That's all.
Correct. Again, think the OS. Now, OS is very interesting. The median OS is actually quite large. Even if you look at the hazards, is still 0.76, not met in the full population. A 12-month OS is around 80%. So this curves look better, but remember, this is only 12 months. We need updated data. And again, when the ESR1 is there, then it seems to do slightly better. So again, maybe I am biased. I don't really
But
think
this again, no. The question is, first trial, the one that you talked about, Emerald.
Yeah.
You are again talking about IMLU versus
No,
just a standard of
IMLU
care.
versus this was the Ember trial.
One arm.
Correct.
But the one arm had Abima. It's Abima arm that did well.
Correct.
The second trial is everolimus in both arms.
Correct.
Okay.
Correct.
The third one, this one does not have a partner drug. I feel that, whatever it is, even in second line, we are going to use a partner drug. It is not that we use only a third and we don't use a partner drug. There will be a partner drug. So I think, although these trials, they are showing a magnitude of response, we are not going to use these drugs without a partner drug. So I don't think that, these hazards have much relevance now. Only the trials that have partner drugs compared will have a
absolutely the point I was getting to, because again, when you look at the other trials, you have Amira 3, MSS strength, which was negative, Girard strength was negative if you used the monotherapy. So again, that's the point which I wanted to bring around, that do not use elacestrant as a single agent. It should probably be one with something else. So the enthusiasm of a third monotherapy should not be there. Yes, Dr. Nilesh.
No, I think Soumya said it right that time, that single agent SERDs, especially in this setting, are out.
Correct. I completely agree with that. Again, you have new ones. You have this Vepdegestrant, which was there in, I think, ASCO this year. Again, 5.2 versus 2.5 as a monotherapy. Then you have Serena 6. Now, Serena 6 is a very interesting trial. Quickly, Dr. Nikhil, your thought on the Serena 6. We all talked about this. This is like you're getting a lead bias, and then you're getting a PFS advantage of close to 12 to 12 months. That's a huge impact. But would you be happy to do this? Do a ctDNA, jump the gun and change your drug? Dr. Nikhil?
So, I mean, there is a lot of excitement as well as equal amount of criticism for this study in view of the way it was designed. You have to actually have a big funnel to really get your patients out of it and just try to pick up those ESR mutations only in a certain way through certain, I think, through Garden and all that. To my mind, it's quite challenging to do a practice like that in the day-to-day practice. The only positive aspect of this particular study, what has been highlighted, has been the better quality of life was maintained much better. That is, I think, more, I would say. Otherwise, comparing PFS3 to PFS2, so there are a lot of, I would say, issues with this trial. So probably to my mind, it's too difficult to do that. Or then if you do it, then you have to decide what level you are going to do, only SR1 mutation, how we are going to do it. But yes, it's a positive study for all practicality.
Correct. So again, I not, and we talk of toxicity being better for a SERD versus a normal AI or a normal fulvestrant, and we have been using those for donkeys here. So I don't know how much that really matters. This is the summary kind of slide. So Evera and Ember 3, the IMLU the group with the EBIMA, either you do that or you do a Jira plus everolimus. So essentially, you do a combination. I think that's the way to go forward. We have only 2 minutes. Pick 3 AKT quickly. You have options of inavolisib, alpelisib, everolimus, capivasertib. So, Dr. Soumya, your take on which of these would you use? Which would you not be happy with?
So I'll be using inavolisib plus palbociclib plus fulvestrant. There is the Inavo 120, or else the giredestrant plus everolimus.
Remember, the Inavo did not have prior CDK4/6 inhibitors.
So I know that. So that is one of the ways. So pick 3 CA, if it is there, then that's what the camigestrant looking at the ESR1. But sometimes the ESR1 and the pick 3 CA.
So my point is not that. Everybody more or less said that we would be using CDK4 in first line any which ways. So then what do? Do you use this kind of a approach, or would you use the capital A approach, which has 73% prior CDK4/6?
So
Remember,
that I will look into the PIK3CA upfront also
very good.
before
So I think the
starting.
other thing which was there was the gedatolisib plus fulvestrant, a good trial looking at wild type. And what they looked at again was only this arm, which is the PIK3 wild type. The mutant we still don't have. Again, three arms, triplet versus doublet. And what they found is that the triplet of the three drugs seem to do well again in both these settings. And the PFS there is definitely much better. It's 9.3 versus 2 months. So again, the theme is the same. You're getting the PFSs. OS, not always you're getting. The interim OS here was again non-significant, though the interim analysis median is still better by around 8 months. So that's a good result. So this is what probably we'll be looking. Victoria 1 is, I think, among the more interesting kind of drugs that we are going to be getting. So I will not go into too much detail on the other things. CDK in re-challenge, and then we'll probably close because we are done with time. So Dr. Nilesh, CDK4/6 re-challenge or one of these fancier things, what would be your approach?
So, so I would probably consider it more based on an NGS and more based on the presence or absence of a PIK3CA inhibitor, a PIK3CA mutation or an ESR1 mutation. So I would prefer to do the targeted approach. Again, it would also depend on the volume of disease and the tempo of the disease. Both of these are important in taking this discussion. But this is one place where I will give importance to the NGS findings.
So again, for me, the post CDK is what we will do in India because we don't have anything else. But when you look at the results, it's still that 5 month, 4.5 month. You're not touching that 8, 9 month, which you're touching with the Ember or with the other study. So that's how I would take a look at it, right? So this is about the thing. Last bit, how to place the ADCs. I think only place we would put it is if there's a resistant disease, progression within 6 to 8 months, rapid progressors. That's where you would use a TDXD as a DB06. Remember, the DB06 had around 40% of PIK3 or ESR1 mutants also. So if they progressed despite having a CDK4/6 very rapidly, that's where you would use a TDXD. You could use the SG. So if somebody talked of chemotherapy-free treatment, this is the chemotherapy-free treatment. I'm not sure all of us would agree that TDXD is so much easier to use than a chemotherapy at the cost that is involved. But that's how it is. And I remember Dr. Sudeep sir always loves saying that capstabine keeps on working. And TDXD versus capstabine, if you have to make a choice in terms of side effects and benefits, I think it's always going to be a little difficult. So at the end of it, I always, after making all this presentation, I really felt that I was a kind of an idiot, signifying nothing because ultimately in India, what are we going to do? We are still going to use CDK plus ET as the first line. SERD's cost effectiveness really needs discussion unless we get it in a big way in India or in a clinical trial. I don't think we should go out of our way to procure SERDs. It's something like the tarlatamab for SCLC where the cost is prohibitive. Would you go running behind it and force your patients to buy it? I'm not sure I would still do that. As of now, only PFS benefit, toxicities are there. PIK3 ESR1 still should be tested because it is prognostic. PIK3 mutant, we do have alpelisib for those who have used it with all the issues with alpelisib. We still use it. Capivasertib we don't have available. P10 AKT probably capivasertib, but remember still no OS benefit in any of them. ADCs are coming in. At least the TDXD is available now, and we could use it in this subgroup of HER2 low and ultra low patients. So that's my take. And thank you for all the panelists. And thank you, Dr. Sahu, for giving the chance. Any questions or any discussion, I would be happy to take.
I don't think we have answered most of the chat. Any panelists have anything to say? We have a minute left. No.
The only word about the gedatolisib was that it's IV injection. It has to be given once in a week. So it's not something, I mean, although the data looks very promising, it's always about how the practicality of the Victoria 1 trial, what we had shown. So I think all the slides what we have shown are quite important to us to really understand. But at the end of the day, as you rightly mentioned, we still bank on CDK4/6, followed by again something like a maintain switch to CDK4/6, and that is probably, I would say, what we would be doing, and look for some HER2 somewhere in between. That's my take on that.
Can I make a quick point?
Yeah,
So
sure.
even with regard to sacituzumab govitecan, it seems that it's better to use it much later than earlier because we had the Ascent-07, which has turned out to be a negative trial as compared to probably the Tropics 2, where it was given in later line. So, I mean, it's a very expensive drug. So where you place it in your treatment journey is also important.
So basically, the take home for me after we go through is that yes, CDK4/6 plus hormone therapy becomes the first line go to for all of us, and all the three drugs look similar with different toxicity. The survival could be affected because of multiple factors. Number two is NGS at the front line. Most of us agree we won't do it. Three, you may do it because it's a truncal mutation, or you may do it later on. But second line post progression, the panel agreed that NGS is the way to go forward. And here it is liquid NGS in contrast to lung, where it is solid versus liquid, the debate goes on. And once the ESR1 is there, then what we saw was that you need a triplet now rather than, or a doublet rather than a single cert. That is where the world is moving. And even the Victoria told that in the big three non-mutated, again, it's a triplet. So that's where we are moving. The toxicities has to be taken care of. There are unique toxicities. So with that, thank you, Vamsi. Thank you, all the four panelists. We'll move on to the second panel, and this is on metastatic HER2 positive breast cancer, and we have Dr. Rajiv, who is from Chennai, a senior medical oncologist, Apollo Cancer Center, and he will be moderating the session. And his panelist will be Dr. Chetan Deshmukh, a senior medical oncologist from Pune, Dinanath Mangeshkar, Dr. Chandrakant. I think he will join in a minute or two. He's a senior medical oncologist from.
I'm there, sir.
Oh, Chandrakant, thank you. So Chandra is there. Bharat, again, a very dear friend, senior medical oncologist from Secunderabad or Hyderabad, the Twin Cities. Ghanshyam Bhai, a very dear colleague and senior and friend from Bhubaneswar. We know all. And we have Vishwajit Dubashi, who's a professor, medical oncology. Thank you, Vishwajit. We missed you yesterday because you are traveling. Today we will use you. And he's from Chippa, Pondicherry. Rajiv, your
Yeah.
slides are loaded.
Yeah. So good evening, all. I think now we come to one of the more exciting sessions because
And you have 35 to 40 minutes.
sure, that is where all the news has happened. And I just shared the session, and I think I had shared, but it has not come.
You send a backup?
Yeah, I've sent a backup also.
Yeah. So no, sir, it's there with you. Just reshare it, sir. I think you shared the slide and then it was removed. So you just reshare, sir.
Oh,
Else we have a backup also. So Geetika will be ready with the slides. Geetika, you're there?
So try once more, Rajiv, because if
Yeah,
you
yeah.
Yes,
do it,
sir.
you can control it better. Wait for a minute. Let him try, otherwise we'll go for a backup.
I'm just trying again. 1 minute.
Yeah, just try, otherwise we'll go for a backup.
Got it. Yeah.
Vamsi, you are there? Or Nilesh or Soumya?
Yes.
Soumya, there's a question in the chat by the time company. It's from Chaitanya Patil. So what are the toxicity of gender restraint? That's what she wanted to know. Any significant toxicity which you would want to bring to the notice
Rajiv,
of
sir, we
everyone?
can see
The
your slide. If you
trial,
can make it full screen, please.
I just
Yeah, tell me. Soumya, you go on till they make the slide.
in the trial, the gedestant had a bradycardia of 3%. That is where we will be a little bit looking. And again, it is oral third. Again, so
Is it seen?
Make it full screen, please.
Yeah.
Go
So
down.
go.
Yeah, make it full screen.
Yeah.
Yeah,
All-
you're
all
all
good
good.
then.
Soumya, you just complete and then Rajiv takes on.
Yeah, so we'll have to look out for the bradycardia. It is around 3% in the trial. And then ocular abnormality was not much of there, but it can be one of the side effects. No other major side effects.
The commonest is musculoskeletal.
Yeah, mucositis and musculoskeletal would be the other
That is
ones.
most common.
What happened again? You went back.
Yeah,
please.
I'm ready.
Yeah, so we are on with the next panel. Please, Rajiv.
Yeah, so good evening all. So I think we look into one of the more interesting sessions, which is about HER2 positive. A lot of noise being made at SABCS and ESMO. So I'm sure my panelists will share the equal excitement. So we could see why it is happening because you could see the crowded place in 2025. We have, choices of many. We have tucatinib, TDXT plus pertuzumab and palbociclib in HR positive. So we have a lot of choices. There are plenty of choices. So I would ask each one of your panelists, what is your current treatment of choice for a de novo metastatic breast cancer with HER2 positive with 2 or 3 liver mets and few skeletal mets? What would be your choice? Each of the panelists can take.
I may begin. My choice is dual HER2 blockade with trastuzumab and pertuzumab along with a taxane.
So the Cleopatra, yeah.
Yes.
So all the other panelists agree to that, or is there any subset where you would not consider dual HER2 blockade? Yeah, he's Tarnish is HR positive and triple positive, yeah.
So Rajesh, so I think so there will be a group of patients like they may not tolerate docetaxels. Neuropathy may be a problem even with the nab-paclitaxel. So here probably you can switch the chemotherapy arm to the Emerald trial. So this is a non-inferior trial.
Yes.
And eribulin. So that can be one of the choices. So this is since 2000.
My question was, is there any subset of patient would you use only trastuzumab? That means no dual HER2 blockade. Any panelist? Or all of us use dual HER2 blockade for all our patients?
Dual blockade.
And now today the generics are available, so that question becomes less valid today.
Okay, so even if the logistics are sorted, we still try to give dual HER2 for all the patients. So I think this is where the crux of the presentation is going to decide. So we have the Cleopatra mature data, then the DB09, which was presented in ASCO and updated in ESMO with some subset analysis, and we look at Patina trial and also in detail look at HER2 climb. So if you can see that there are 2 maintenance options, and then we have a chemo-free options and also prolonged use of TDXT. So we will see each one one by one. So if you can see that it was 20 years of adjuvant trastuzumab has been celebrated. So that means we have come a long way. So the Cleopatra, which was published in 2012, it is 37% of patients have 8 years overall survival, and still 16% of the patients are on Herclone or pertuzumab. So, Dr. Chetan, do you think in practice we are able to see these good results, and how long you continue to give your HP? What are your thoughts on the updated Cleopatra data?
I continue to give the chemotherapy arm continues till the patient is able to tolerate. Usually, I am able to manage about 4 or 6 doses of docetaxel or an equivalent of weekly paclitaxel or nab-paclitaxel. The dual HER2 blockade, the problem is only with pertuzumab-induced diarrhea. Otherwise, trastuzumab has been a very smooth drug. We've never had a problem. We've all had patients who had received trastuzumab for years on. The only problem with pertuzumab is the cost and the diarrhea part. Otherwise, if these 2 things sorted out, I don't see any issues there.
So in practice, you are able to continue long term in majority of patients. That's what I would take it.
Started using trastu-pertu only recently because the availability improved only recently.
Yes.
But yes, so far I have been able to deliver most the dual for most of my patients.
Okay. Biswajit, Tarini had a question that it was ERPR positive. So if ERPR is positive at the end of chemo, would you add hormonal therapy also to maintenance HP?
Yeah. So
Yes, sir.
okay. Sorry,
Yes,
Rajiv, the question was for me or?
Yeah, you can answer, then we can ask the others. Yeah.
Yeah. So for hormone positive, we would continue taxane till toxicity or till manage. I mean, generally we give up to 6. Max I have given up to 8 doses. After that, docetaxel becomes difficult to give.
Yes.
And then we would continue hormone therapy along with trastuzumab and pertuzumab. And the second question which you said about continuing the therapy longer, I agree. Sometimes pertuzumab becomes a problem on long-term basis when, as already said by the previous, that some amount of diarrhea, fatigue, skin and other side effects come. 2-3 years they go, and then after that they try to stop the drug, and we just continue trastuzumab sometimes. But it's difficult drug to give beyond 3-4 years.
Chandrakant, you wanted to add something?
Let's go.
Sir, I agree. I would give Cleopatra to all my patients.
Yes.
And in hormone positive, I will give CDK4/6 maintenance.
Yes.
And if Even tucatinib also can be used in the maintenance after completing chemo.
So I would take it as you would go Patina way in majority of your patients.
Cleopatra follow.
Yeah.
Right.
Because, okay. So,
Parik sir wanted to raise his hand. Parik sir?
yes, sir. Parik sir.
No. Yes, we go on. Okay, go on, please.
So I think in Cleopatra there was the continuation of hormones was not part of the deal, but in practice, as Bishwa told, most of us would use it, and Chandrakant's the strategy we will discuss how to.
Best. So the best data is with Patina in terms of overall PFS improvement, 44 months. So
Yes.
ideally,
Okay. Yeah. So we'll discuss Patina in the coming slides. So this was the big one, the HER2 positive MBC, the DB09. It looked at randomizing patients to TDXT plus placebo, then TDXT plus pertuzumab, and then we had the THP arm. The endpoints was PFS, and the secondary endpoint was overall survival. It was well stratified. That means it was de novo versus recurrent, and HR positive or HR negative, and then the PIK3CA. So we had the ESMO update, which showed that the PFS, the primary endpoint was very clearly met with hazard ratio of 0.56 and a consistent PFS benefit with TDXT and pertuzumab was also observed across stratification factors. So I would discuss with Dr. Chetan that in the neoadjuvant setting we had the DB05 where they were looking at only TDXT. So here TDXT and pertuzumab was used. So is there any synergism when we use TDXT plus pertuzumab? What are your thoughts on the basis of this trial of showing such positive result?
Well, there certainly seems to be some synergism, but honestly, I don't know the mechanism, though the PFS results look quite impressive.
Yes. Professor Ghanshyam sir, your thoughts?
So I think, so once both the synergistic means it is almost a pan HER2 blocker.
Yes.
Yeah, so that's probably, and you are taking the advantage of the background noise when you are adding an ADC.
Yes, I think there was a good baseline study where the synergism with pertuzumab and TDXT was well demonstrated, and in neoadjuvant, but we still have only TDXT alone data, so that's a bit of a discordance. So if you look at this consistent PFS was there in HR negative and PIK3CA mutation, which was almost 30% of patients. So do you think that will be relevant with this data coming up that, PIK3 mutation, it works quite well? Will that be a good option for our patients in the later line, Biswajit?
Yeah. So this PIK3 is also with the HER2 positive. So our data with PIK3 and the HER2 positive, I'm not sure how much prognostic is it in that subset. So I have no idea on that. So, but the drugs definitely seems to work. Just one point I wanted to make about the previous question was that the data for the TDXD, there were 3 arms, but they have not actually reported the TDXD single arm.
Yes,
which means that actually the interim analysis did not show that the TDXD arm actually showed a benefit, and they have blinded it. They did not want to open up so that there is no. So it looks like pertuzumab is doing something.
Yes.
With the TDXD. So I think there is some effect of the pertuzumab.
Yes, I think it would work better if we had those data in neoadjuvant. That's what I was trying to tell you.
There are some data there, but again, we don't have a clear-cut idea.
That's
now.
True. Yes,
this
yes.
is debatable.
Yeah, but in a metastatic, at least it is proven that DB09, when you combine TDXD with pertuzumab, it really has a synergistic effect. Dr. Bharat, so what do you think the merits we have seen? It works across subgroup, HR negative, PIK3 mutation, whether it is de novo. What do you think practically the demerits are, or do you think it's straight away practice changing and we can use for all our patients?
Sir, I have my own apprehension here. The thing is, we have used, all of us have used Durastic, but sir, there is definitely some degree of toxicity
Yes.
Everybody will agree, right from vomiting to start with hematological toxicity, ILDs. And if you see DB09, the median duration that the drug was given was 20 months.
Yes.
With the cost involved, with the toxicity involved, at least practically, I have not given for 20 months, so I'm not sure. Secondly, sequencing is a thing. The other arm did not have a maintenance. So
Yes.
we know patina, we can go, this DFS goes till 44 months. So giving now or giving in the second line as per as DB03 with a 28 months PFS, probably we may go up to 70 to 75 months with this. Issue will be when you have given a TDXD in the first line, they progress. What about the second line? So many apprehension. The cost, the long duration, the toxicity, the way you sequence. But saying this, if I have a patient, what you have already discussed with a de novo brain mets,
Yes.
I can think of it with the DB12 study, impressive data. If a PIK3 mutation is there, I think so that is by far a prognostic. With a poor prognosis, I may think of this. And a third, very bad disease like involving a liver and meds. So probably you need a better rapid response again. So maybe in a subset of patient, yes, I will think of giving this more so in a de novo brain, but not for all patients. I think Cleopatra will still hold its space, followed by Patina. I think we are more or less achieving the same, and I will keep it for a second line as well as DB03, where I may have a PFS of 28 months again.
Very well
70 to
said,
70.
Bharat. Yeah, practically, I think very well
Because
said.
I mean,
But
so
Chandrakant, I just wanted to, yeah, yeah, please, yeah.
So I have a patient who is completed almost 2 years on TDXD, absolutely no toxicity.
Yes, yes, I
But
think it's
on the other side, I have a patient on fourth cycle had an ILD, though some response, I did try to re-challenge but progress. So there must be some clinical biomarkers or something that might come up, that there are some patients who land up in toxicities too early. So they may not have 6 months at 6 months, but there are patients, one patient who is completed 2 years, absolutely no toxicity, now neither neutropenia, no GI toxicity, and she continues to be in remission at fourth line.
That's true. So I think that's why I'll continue to ask you. So I think Bharat really mentioned all the practicality and how we will be choosing only for few subsets of our patient. But a PFS1 of 40 months, don't you think that is too tempting for us to use for all our patients? Or
Absolutely.
yeah.
So now at least some, because with the PAP available and soon, so our colleagues will start. We have started using a low dose. So even at AIMS Bhubaneswar now, Dr. Saurabh has 10 patients where he has used 100 milligram. So I'm not advocating it, but so these patients continues to have a response.
Yes.
So it is definitely a tempting, and it is a practice changing, because these are patients, so such a good PFS. So I think so definitely, if money is not a constraint and the background ILD is not there, then definitely I will use it in the first line.
So I think Tarini has put in the chat box that Patina also may give us an option, and with all the generic palbociclib, that would be an option. So Biswajit, what do you think are the challenges that we see as far as Patina is concerned? Do you think we can use it for all our patients? What do you think are the practical difficulties?
So the Patina trial included Palbo, but if you look at the Patina trial, the inclusion criteria, many of these patients first did not get pertuzumab in the neoadjuvant setting, especially for patients who progressed after that.
Yeah.
These are patients who are receiving basically hormone therapy with CDK inhibitor and trastuzumab. And I think it's a good way to give maintenance, and it's showing 40 months of PFS benefit. And
Sure.
it's easy to give. We already are used to giving CDK inhibitor.
So,
and that is the rationale also behind
yeah,
it.
I think like any maintenance trial, here the randomization happened after the best responses here, both in Patina and HER2 climb, which we will discuss in detail. So do you think is that a concern? Early progresses were taken out, or is there any early progresses we will see with the THP? Is that an issue you considered? Because when we are looking at the trial, did they take out only the good subset and then that's why they got this PFS, unlike the TDXT where it was all comers?
Yeah, so this is basically we are looking at a maintenance therapy. So the question is, even when we did the TDXD, whether we should do a short TDXD and then go with the maintenance, because we know that the longer we give the TDXD, the toxicity and problems are there. So one is to choose the right patient for TDXD, as Dr. Bharat had clearly said, that high risk patients, you want a faster response, deep response, brain mets patients, you are going to do TDXD. But also, are you going to continue doing this TDXD for 2 years, 3 years? Down with toxicities and all that. So in that situation, you do TTXT for a shorter time, have a response, and then put all these patients on a maintenance therapy. So I think this is what works in a maintenance therapy. So obviously we know that the progressors are going to be taken off and you're just going to put them onto a maintenance therapy.
So again, I think Dr. Gansham, you had mentioned how long would you give chemotherapy before you put the patient on patina? So let's say after 4, you saw a PR. After 6 or 8, it is still disease is there. Few of the liver and lung lesions are there. So would you continue chemo till CR? So will you be increasing the number of cycles when you? Yeah.
So I don't think so that we will continue. So the maximum responses or the tolerability. So we have stopped even at 4 cycles. The maximum cycles we have given is 8 cycles. So even at 4 cycles, if somebody has achieved a good response, I know that beyond this, so I may not be able to continue the treatment because docetaxel and pertuzumab both producing an GI toxicity, especially diarrhea. So I can, if my patients are hormone positive, so definitely I'll switch over to CDK4/6 and continue as a maintenance.
Sure. So I think this points has already been discussed. So this is one of the valid option in an ER positive subset, as Nikhil had mentioned that HR negative TDXT may work better. And then we have this. Will this be an issue if you are going to give IV drugs? Sometimes if you are on fulvestrant, then you have IM, then we have oral. So multiple drugs, multiple routes compared to one simple drug once in 3 weeks. So is that a problem, Dr. Chetan, in practical situation?
No, not really. In fact, I feel that Patina trial is one of the most practically applicable trial for Indian population. We have a subset of patients who has responded well. They need a maintenance. Palbociclib is a drug which is like easy to handle. And even if a patient is on fulvestrant, it's only the first month that the fulvestrant is going to be given more frequently. Subsequently, it's going to be monthly. And that can be timed. That should not be a problem. So fulvestrant is not an issue. The chemotherapy part, well, most of us will, as Dr. Ghansham rightly said, we won't wait for complete response, which is anyway quite unlikely in strong HR positive people. So probably after reduction in the volume of metastatic disease, we are happy to go on to a maintenance strategy as is charted out in the study.
Then I can ask a simple thing. What is the progressive disease in Cleopatra? If you look at the PFS curves, it at 4 to 4 months, it is around 8 to 10% only.
Yes.
So basically, you are still having a 90 plus patients still responding to Cleopatra at the 4th month. That's where most of us will stop chemotherapy.
I think that's the point which I think the panelists were trying to make, because your early progressors are less. Again, I think Chandrakant, I think yesterday, I think you made a point that we can, easily substitute CDK4/6. So will you be tempted to use ribociclib or abemaciclib here?
Right. So there is no data as of now. But theoretically, yes, they have done better in the
Actually,
metastatic.
Chandrakant, just to view, there is a small data from ribociclib, exactly the patina way. There were small data is there for ribociclib doing the same benefit actually.
That I may use abemaciclib if there are brain mets, so replacing.
So I think that's interesting, because in this study they had significant reduction in the CNS metastasis. So the synergism is somehow working for palbociclib, at least in this trial. So now we come to the star of the evening, the HER2 climb. A lot of noise being made at SABCS. So we will see how practically it is feasible for us. So this was a very well conducted trial. It looked at HER2 positive disease, no progression after 4 to 8 cycles of THP. I think we discussed the duration for Patina. And then no or asymptomatic brain mets on screening MRI. So there was a screening MRI for everyone. And then they randomized to tucatinib 300 mg BD every 21 days versus a placebo every 21 days. So I think a very straightforward trial design with the PFS being the primary endpoint and secondary including OS and the CNS PFS. So if you look at the final OS analysis, there is some some tendency for OS benefit. And if you look at the brain metastasis cohort also, there is significantly reduced as the site of first progression. Even in a pre-treated HER2 positive MBC plus or minus bone mets, there was improved PFS and OS. Here is a drug which we need to use prolonged. So some of us have used in metastatic setting already in the subsequent line. So if you are using in a maintenance therapy, then you have to sort of compare it with palbociclib, which otherwise you use, or TDXD go. So here are the side effects profile. You have 73% of patients having diarrhea, although grade 3 is 6%, but it's going to be very troublesome for our patients. And also transaminitis, which is quite significant, grade 1, grade 2, but grade 3 again less. So, Dr. Chetan, do you think is it feasible in our population and we should adopt this approach in at least some of our patients? What is your take on this?
Yes, I think so. For patients with brain metastasis, this seems to be a very good strategy because tucatinib has shown good activity, CNS activity. Diarrhea part, well, I think the diarrhea, even for other drugs, has been a problem, but we have been able to take care of it. The original study of tucatinib had capecitabine, and there it was a troublesome side effect because both drugs have the same side effect. But here, with the other drugs, it should not be so much of an issue. And you have rightly mentioned that the grade 3 diarrhea incidence is much less, not as high as the all grade diarrhea.
Biswajit, what is your take? Prolonged tucatinib maintenance vis-a-vis TDXD?
So this is an option in hormone negative HER2 positive. So we know that trastuzumab, pertuzumab, at least 10 to 15% and maybe more will subsequently develop brain metastasis. And tucatinib is one of those drugs which has a very good CNS. So as a part of that, that's a good option. But only problem, as we discussed, is the tolerance in terms of diarrhea. And as again suggested, that capecitabine obviously increases the diarrhea, and I believe that if it is only tucatinib, maybe it is lesser. But again, we have to be very cautious in use because again, we have to give it on a prolonged setting. So that will be an issue.
Yeah, I think again in the trial setting itself, almost 14% of patients had discontinued. So that's something we need to be looking into. But as rightly told, this can be a valid option by the PFS, by the HR status and the CNS PFS, which is definitely going to make a difference. So if you just do a cross-trial comparison, now we have the DB09, we have HER2 climb and the patina. The interventions are different. The drug mechanism of action and the route is different. The number of drugs which has to be given are different. The timing is different. But if you look at the PFS, with a single drug TDX1, you achieve 40.7 months. As Sahu was mentioning, even with the patina, which is much more feasible with us, we get a 44 months PFS, although we don't know how the OS is going to mature. We need to be worried about the toxicities, ILD, nausea, and then of course diarrhea for tucatinib, and fatigue and neutropenia, which most of us sort of sorted out for palbociclib. With all these option, if in a patient who is HR positive and who has had a good response to THP, will patina be the choice for majority?
Yes.
Yeah.
Sir, probably yes. Patina will be most of the time, our treatment of choice. We have used palbociclib, I think I can say from ages now. We are comfortable, simple treatment, equivalent, or maybe somewhat, if you, although we should never do a cross trial, but 40 versus 44, hormone receptor positive, a good quality of life. Saying this, in ER negative, there was a doubt what to use. So probably here we can always think of Destiny 09 versus the new Herclimb 05, because that Herclimb 05, the best, the quantum of benefit of more than 12 months, 12 versus 24, was in ER negative subset. So, but yes, again, the thing is, at the end of the day, a lot of other things, cost constraint, but is there toxicity? I think tucatinib, yes, there is diarrhea, but grade 3 diarrheas are less, sir. So, and if you see the toxicity of Destiny 09, also the discontinuation rate should be more or less the same, sir. So you have to pick and choose your patient, but for ER positive, hands down Patina. ER negative, yes, again, both have the same brain mets, both works the best. DB09 definitely has a better data of 40 months. Maybe in ER negative, it is slightly lesser, 36. But I think, yes, that there ER negative, we can always debate between what is there. For ER positive, I think so. The data both is impressive, and we have to pick and choose. Only thing is, brain mets is something where you have to think differently, where you have to think of other thing, and a pick three, what you discussed briefly before, sir.
Sure. Chandrakant, if I can safely tell with all this discussion that in a significant number of patients, still we will be using TDST as a valid second line option?
Yes, sir. I think TDSD is a valid second line option. First line is still Cleopatra followed by Patina. And second line will use TDXT.
The PFS was 24 months in HER2 this trial.
HER2 climb, yes.
Yeah, so it's 25 months.
Yeah. So again, that we told, they're taking, already the good job has been done by Cleopatra arm, and then they.
Yeah, so basically, then if you look at the DB09 and the Patina and this trial, so in a hormone positive, we go for Patina, as all of us told. In a hormone negative, your pockets are deep, and a young fit patient, then 09 looks very, because the PFS is way ahead of that.
Yes. And I think that is the sort of crystal ball looking, that if you get such a good PFS and then you get more CRs, many of them may not require a second line treatment. And I think if you discuss that with patients, and as Sahu told, if logistics is not an issue, then I think some of our patients would discuss that option. And of course, the CNS metastasis prevention, if it is significantly low. I think these are the pros. But then, finally, we know that I think, Dr. Vamsi also discussed TDXT is not an easy drug to give. We are still learning, and some of them get into trouble. In the neoadjuvant arm, there was 2 deaths with the TDXT. So these are things which we need to be very careful before we adapt that to most of our patients. And second line TDXT, as very well told, would be one of the valid second line option. So I think these are a few of the discussion points they had in the SABCS. If you are giving TDXT, how long do we give? And whether you can, de-escalate to pertuzumab alone or TDXT monotherapy. And also, as Biswajit mentioned, there is an arm for TDXT alone, which has not been, we may get in the near future what is the data for TDXT arm. And whether does everyone need pertuzumab? As I told, the synergy is known, but does everyone need pertuzumab, or in a low volume favorable disease, whether TDXT alone will be good? So this DB09 TDXT monotherapy results are awaited. So Professor Gansam, will you be able to give us a guess or crystal ball on how TDXT monotherapy pan with all the data that we know about in the neoadjuvant setting?
In the neoadjuvant setting, the passive are not much. So
very impressive, yes. So you're not sure whether TDXT monotherapy will be as good. Is that the guess? So I think this is what the panelist has been trying to tell. Although we don't have a real low risk, high risk classification like prostate cancer in breast cancer, but more and more personalization may be as we may have to do by looking at the subset analysis of all these trials. So if you have a high visceral burden, if you have PIK3 mutation, if you have brain mets, as Nikhil was telling, and if there is a early relapse, then or HER2 heterogeneity. These are the patients where TDXT plus pertuzumab may be useful. If you have a low risk, low burden, non-visceral oligometastatic disease, maybe the docetaxel, the Cleopatra way should be good, and then you follow it up with patina for HR positive and tucatinib in HR negative. Is there any comments on this sort of presumed clinical approach, Dr. Biswa?
No, I think beautifully
Agree.
summarized. We need to
Agree.
risk stratify and completely agree with this.
Yeah, I don't think this is with any hardcore data, but I think this was the discussion that happened in SABCS and looks reasonable to use it in practice. And of course, there were some papers, paucity of time we won't be discussing, but looking at personalizing with HER2-DX. So if you have a high score, then you have a longer PFS, and of course, other integration of omics data or biomarker driven. I think a lot of ctDNA was discussed yesterday. So I think these are in pipeline, and especially for HER2 positive, I think this will make a difference in selecting which of the drugs as first line and whether we can stop at some point of time or how long the maintenance therapy has to go on. So I think these are the basic discussion we had. Should all patients receive TDXT plus pertuzumab? I think we had practically discussed that may not be required, and patient factors, some of them which was very nicely described by our panelist. And the evolving role, maintenance is here to stay, and with the generics around, most of us will be able to use the patina way. So if you are using first line THP and you get a good response, go with palbociclib, and if it is ER negative, try to add tucatinib. But what happens if you have a TDXD induction, whether we should go for maintenance, those things are still not clear. And whether personalizing systemic therapy in the first line using biomarkers, as I mentioned, would be the right way to go, and then refine treatment duration and de-escalation if possible, and escalation also if required, and early stoppage based on the biomarkers would be the ideal way to go. Any comments from our panel, and then we can try to wind up.
Okay, there are two questions in the chat. Maybe Biswajit or Chandrakant can take this. It's Kishore Kota has put it. HER2 positive, symptomatic brain mets, first line, and he wants anything other than DB09. Biswajit or Chandrakant? Yeah,
He wants a drug or
no, what is the approach
protocol.
that you are going to use?
Approach.
If
Symptomatic brain
DB09
mets
is not practical, is that the question? Yeah.
is not practical, and
Yeah.
other than that, what do you want to do?
Yeah.
So if okay, TDXD is not the option, then TDM1 is an option, and
So frontline. You are using it. It's a.
So Sahu, if
metastatic
I
de
may,
novo.
in the HER2 claim, there was brain metastasis included, but they were asymptomatic. So they had a MRI brain, and that subset showed improvement. So if you are not able to do DB09, do THP, you take care of the CNS metastasis, and then add tucatinib, may be a reasonable option.
Probably radiation to be added, sir. Probably local
that is must. I think radiotherapy and do a Cleopatra also is a decent way of doing it.
Absolutely, yes.
Oh, okay. So second question from Babu, Venkat Pradeep Babu. Maybe anyone can take it. Bharat maybe. For metastatic breast cancer, HER2 positive, HR negative.
Yes.
Asymptomatic brain mets.
Sir, already has spoken. Either of the two options are, if the coffers are deep, probably DB09 is here to stay. If we have some limited or something like that, then tucatinib-based regimen. At the end of the day, both are good, but all these individualist factor we need to decide cost always a constraint, performance status will always be there, but both the options are there for us. DB09 has better data. That is the only thing. But then again, it will be depending upon patient to patient, sir.
Yes.
Ghanshyam bhai, last word, and then maybe Rajiv
Yes.
can tell his final.
So don't forget lapatinib and
Yes.
for all of our patients.
So we had a full panel without lapatinib.
Yeah, just one point is that many of these trials, active brain mets have not been taken.
Yes.
So when we say that we are going to use trastuzumab and pertuzumab in patients with brain mets, we need to take it with, I mean, we need to give radiation and we need to be careful.
Treat it with radiotherapy. And
Yeah.
after stabilization, if they go to Cleopatra, is there a problem?
I think the question was if DB09 is not practically feasible. So
I agree. So Vishwajit, what you spoke, if a patient is having a brain mets, as we do, give a radiotherapy, and in 1 month the steroid is stabilized, the steroid dose is okay, the patient is okay. Is Cleopatra not a valid option then?
Yeah, it is. But the problem, again, we already know that trastuzumab, pertuzumab are not very good drugs to cross the brain. We have better drugs.
Once the RT is given, will that barrier not be broken?
We don't know.
Yeah.
I mean, I don't know this answer, but the question is that we have other drugs like tucatinib and other drugs, which we need to probably use lapatinib, tucatinib, TDM1 and all that. So we need to carefully choose which drug.
I think on that note, I thank the interactive
Rajiv, you have to take the last question for Hemant sir. Can we combine TDXD with tucatinib?
TDXD, tucatinib, we don't have data.
Toxic. And no
It will
data.
be too toxic. It will be too toxic. Yeah. So we stop here.
Yeah,
Thank you,
thank
Rajiv.
you, Tarini, for being the taskmaster and for a very interactive panel. Thank you.
Thank you, Rajiv. Thank you, all the panelists. We go to the last panel before we take Dr. Sendil's top 5 or 4, whatever he has prepared. So, can we have the slides for the last panel? And it will be on metastatic triple negative. And it will be moderated by Krishna Prasad. He's a senior medical oncologist from Mangalore Institute of Oncology, Mangalore. And his panelist, Ghanshyam Bhai, will stay on. This photo is nice for the last one. Indranil Ghosh comes in from, and he was there in day 1. He is a senior medical oncologist from Apollo Center, Kolkata. Bharat Rangarajan again rejoins from Coimbatore. And we have Vamsi, who moderated the first panel today from Hyderabad. Please.
Thank you, Dr. Sahu. When you invited me for a deep dive, I was pretty much ready before this happened. So then I thought I'm not going to go there. We will go very shallow deep dive. But then I realized you wanted me to do this. You wanted me to spend last few days really going into the depths of it. I don't know how deep I have gone.
The last one looks like Krishna only.
So these are the 4 panelists. So I got Vamshi's new photograph. So let's go directly to the case. A 45-year-old presenting with decreased appetite, breast mass, T4B, N2, M1 because of liver and bone metastasis. Triple negative, of course, it is mandated by Dr. Sahu. PDL1 is 25% and BRCA is negative. So this is the NCCN guidelines. So if you go to this part, Dr. Ghanshyam, what is your thought now as on today? What would you do with this patient?
So chemotherapy, and since the CPS is more than 10, so I will add a Pembro.
Okay, which is your chemotherapy drug of choice?
Since here the liver involvement is there, so I'll rather pick up a weekly nab-paclitaxel, carbo and Pembro.
Okay, weekly nab-paclitaxel, carbo and Pembro. Okay, that is not one of the standard regimens recommended. Dr. Vamshi, what is your thought on this?
So generally, I would prefer just a single agent. So I'm happy with a nab-paclitaxel with a Pembro if it is more than 10.
Okay. So I think we will ask the others as well. Dr. Bharat, what is your thought on this? Bharat, what is your drug of choice?
Bharat is there. Can someone confirm?
Indranil, can we come to you?
Yeah, I would agree with Vamshi. Nab-paclitaxel with pembrolizumab.
How many of us are actually using the gemcitabine carboplatin combination? Gansham, do you use this at all, and how do you select patients for this? Because see, it's a weekly regimen just like the others, and no hair loss for somebody, lady who is not curable.
So hair loss is not absolutely zero, but yeah, so minimum hair loss, but anemia is a big problem for those patients.
Okay.
These are de novo patient. De novo patient, we do not use gem carbo. That is mostly for the patients who relapsed after adjuvant taxane and anthra.
True,
Fine.
but so this gem carbo has come from a study where they actually use this versus Paclitaxel. So that's the logic of why that gem carbo has come into the NCCN, which is what it is.
Absolutely. So I think all our thoughts are based on this trial, the Keynote 355, which definitely showed improvement in patients with the CPS score more than 10. 16 months versus 23 months is the overall survival. So what I would want to know is if the same patient was actually treated 8 months back in the neoadjuvant and adjuvant setting and now comes with the progression. Indranil, what would your thoughts be? What would your drug of choice be in such a patient?
Okay, so first of all, treated 8 months back, we need to know if the patient received IO in the neoadjuvant adjuvant scenario then as well. Because if received, then that means it was, if we assume that it's say 8 months from the chemotherapy, that means immunotherapy was going on or just about completed. So there is no role of further immunotherapy, I would say. And
so how would you manage this patient with what drug?
Yeah, then gem carbo.
Fine. Dr. Gansham, what was your choice be? 8 months back treated.
So 8 months means the patient has completed treatment 8 months back?
Yes.
So then we have to look at like 6 to 12 months versus less than 6 months. And if the patient has not been exposed to IO, so now you can show I am patient 130, so more than 12 months. And in the Pembro, it was more than 6 to 12 months. So you can choose according to the TFI.
So, Vamshi, your thoughts? This patient has received 8 months back, more than 6 months treatment-free interval. Patients were enrolled in the Keynote 355. What is your thoughts?
I mean, I generally tend to go with the whatever trial has included. So I would check whether trial included 6 months or 1 year, and then I would include if they were included in the study. That's what we are normally doing.
Fair enough. So if you just go into the details of this trial, two things I want to point out that, more than 50% of patients receive gemcitabine carboplatin. For some reason, quite a few of the investigators preferred that drug. And they did include less within 12 months, around 20% of the patients were patients who had a disease-free interval of less than 12 months. And in the forest plot, even though, this is a subgroup analysis, it clearly shows no benefit. So somebody within 6 to 12 months, even though was included in this trial, the benefit was hardly there. Of course, understanding that this is a subgroup analysis. So if somebody has received immunotherapy before, within the last 1 year, maybe repeating immunotherapy might be a futile exercise. In fact, there is a trial in this particular group of patients where the patients had early relapse. And in this particular trial, which was exclusively in these patients, there was no benefit of giving that. What about any other immunotherapy? Cost is always a constraint, and in the Chini bye-bye. Gansham, you are closer to China than me. So do you actually use any of the other immunotherapeutic drugs?
So Vamsi is very fond of toripalimab. No, so he is collecting the data for toripalimab. I don't know if you used in.
Not for breast. I'm not collecting Tori in breast, but having said that, I generally am not considering these as a cheaper immuno. I don't think that's the right way to look at it. The data for these drugs should be analyzed the same way we analyze for a Nivo or a Pembro. And if you analyze it that way, the data is not bad. If you look at it, in fact, the CPS, you don't need to be more than 10. Even more than 1 works in the Tori data, as what I remember. So I am comfortable using Tori. It's a phase 3 trial. It has been published. So if I'm using it, it would be a pretty decent. I'm absolutely fine to use the study to use this drug. They have done actually the almost same thing what has been done by the Pembro study. They have used the same group of patients. They have used the randomization, which is a bit different, but they have used nab-paclitaxel again. So it's fine. Only challenge with this would be the patient population. Tori, if I'm not mistaken, is almost 100% Asian. Asian not meaning Indian. So if at all we have a challenge or a debate on that, we are not Caucasians either. So Pembro has used only Caucasian patients. So
yeah, I
that
will go to Indranil and then Dr. Sao has put up his hand. Indranil, what is your thoughts? Would you use any of the other immunotherapeutic agents? Because the point is, the other immunotherapy agent from the Western world is approved in the Europe, but is not. It has been withdrawn in the US. So, with that background, what is your thoughts on this Torchlight trial, and would you use this?
Yeah, I'm fine. I can use toripalimab in triple negative MBC.
Dr. Sahu?
Sorry, I have no issues in that, but the problem here is the patient. Go back to the one slide back, which you had on the PFS. Yeah. So look at the numbers at risk, and it is characteristic that at 12 months you are losing out, and there is nothing but less than 10%, around 10% only at 12 months. And you go back to the OS, I think the same patient at risk loss will be happening with toripalimab data. No, yeah, yeah. So if you look at the if Pembro data, you won't see that.
Yes.
That is the only issues which I have a lot of the issues with this Chinese immunotherapy. It is, as Vamchi told, the science is there, the data looks good, but the patient at risk suddenly drops drastically, and it is dropping much more than what you see in those landmark trials with these immunotherapy like Pembro or Nivo or whatever it is. So that is something that needs little bit of more thing. That is the only thing.
Yeah, Vamshi, your thoughts on that?
I'm actually looking at it for the first time because, to be honest, I had not observed that. Now, since Sir has brought it up, that the fall happened so
Just look
much
at
in
this.
PFS, I had not noticed that. But if you look at the OS is actually better than the keynote. Again, that is something we have seen in all trials of China. The Chinese IO drugs seem to have a longer OS, whether you call it G junction, whether it's gastric, whether it's even non-small cell lung cancer. Their OS seems to be longer than what is reported in the West. I don't know if it's because. Yeah.
So again a minute here. So if you look at the again Sendil, if he has joined, he can just pitch in. So my point again is, if you look at the OS also, 353 patients in the Tori, and if 36 months is where they've analyzed the last 3 years OS, and it is around even 5% only. It is 30 is 10%, so it is 5%. And if you look at the Pembro data, which I have it on my mobile, and at 36 months, out of the 220, they have 73 patients at risk. So point is, they are just not getting it, and it's filtering out at the end part of it, and they have put a 3-year landmark analysis. So that is the worrying point, that only 5% patients are at risk. While you look at the Pembro trial, at 36 months of the 220, which to start off with, 73 are at risk. So that is something which really bothers me.
Fair enough. I think we will allow
Sendil boss is there, he
on
can
that
just pitch
later
in,
on.
and if I'm wrong, he can correct me. Okay, he'll join.
There. Sendil sir is, yeah.
Yeah, maybe this is part of his analysis at the end. So in this trial, like how Vamshi pointed out, the median overall survival is pretty good, 19.5 months versus 32.8 months. In fact, even in the intent to treat population, it was good. So I think this is an interesting thought process. How do we incorporate the other immuno-oncology drugs, if at all, in our population? So that is with chemotherapy and immunotherapy. Now, this is an ASCO 2005 trial presentation, the ASCENT-04, where they combined sacituzumab govitecan with Pembro versus chemo plus Pembro. We all know, again, nearly 50% of them had gem carbo as their as the chemotherapeutic drug, and the median progression-free survival shows significant benefit. And patients, whether they have recurred early or late, did pretty well, the cutoff being above 6 months. And despite longer duration of treatment with the new drug, the adverse event seems to be reasonably okay. Dr. Gansham, your thoughts on the ASCENT-04 trial? What do you think? with the ESMO 2025, they also looked at patient-reported outcomes, and patient seems to be reasonably okay in terms of their physical and emotional well-being.
So we started with chemotherapy. We added immunotherapy in a cohort of patients. We saw an improvement. So I think so. This is a next move. So we are adding an ADC with immunotherapy, and we have another jump. So this is for a group of patients. But in my few experiences with the SG, it was quite a toxic drug. But it was surprised to see even the quality of life was so preserved. So I don't know, because that was only a 2 patients experience in a later lines. So otherwise, I'm for it. So in this combination, because these TNB patients who doesn't have any driver mutation, so we will have the best chance in the first line only.
Dr. Indranil, your thoughts?
Yeah, I think it was the next logical move, and it's already here. So definitely the data is quite promising. So we will have to wait for the OS result as well.
Yeah, Dr. Vamshi, your thoughts? Is it for tomorrow morning or you want to wait?
The advantage is it's a chemotherapy-free regimen. So SG does have its toxicity, but definitely if you can have a chemotherapy-free regimen, it's not a bad option at all for those who really want it. Is it, again, worth the pricing and the cost? If drugs are available in India, patient is willing for it, then yes, it is an option, I would say.
So would you offer it to your patient tomorrow or would you wait?
As of now, I wouldn't mind offering it, giving it as an option. However, whether I'll not push for it, because I also know that post this in the second line, I can still use my SG. Whereas Pembro doesn't work in second line. We have enough and more data to say that immuno won't work in your second line either as a combination or as a monotherapy in TNBC. So I would have to have my immuno in there. Whether I give it along with SG or chemo, I am fine both ways actually.
So Vamsi, TP has written, is it chemo free? SG is chemo free.
It is, at least the mentality is, it is chemo free. I agree it has a chemo payload and it does have its side effect, which is why I said so-called chemo free. That was how I started. Because if you again, since morning we have been having discussions on the group or what foreigners do and what Indians do. So I think this is what foreigners talk about when they say, oh, it's a chemo free drug and you are forcing chemo. So, I think by the smiles, everyone has been following their discussion. So.
So what we understand is in patients who have got a high PD-L1 expression, all of us would generally offer chemotherapy plus pembrolizumab as the first line. And we would probably wait for the OS data with this new drug and keep this as a second line, most of the time at least. Now, if the same patient has got PD-L1 of 2%, Dr. Ghanshyam, what is your thought?
So BRCA is negative, PD-L1 is negative. So I have an options for chemotherapy, or we can go to the regimen like SM303.
So can I ask, in this situation, why don't we try Tori plus chemo? Tori is more than one is showing us data. I mean, we have a data which is there, which is a drug we have used.
Right.
Ghanshyam, would you take it?
Absolutely. So I'll be even so. I've used in one patient with the less than one with a Pembro. So so the patient responded well to for at least 7-8 months. So there are patients. So it doesn't mean so though the benefit was not there in less than one. So but Tori has the data. So definitely I'll go for it.
Dr. Indranil, would you really offer that, or would you offer sacituzumab single agent over combination chemotherapy with the toripalimab?
So, Krishna,
if I have access to everything, I would rather use Dato DXD rather than sacituzumab.
Both the Dato and this study, the Ascent 3, were in patients ineligible for PDL1.
Agreed.
Yeah.
So they have specified that these patients were ineligible because
ineligible as per the conventional criteria, not the Tori criteria.
That's what I'm saying.
Yeah.
So ineligible in this trial is if the CPS score is less than 10, they are ineligible.
Yeah.
In
Or if the
addition to
patient
that,
had PDL1 positive previously.
Absolutely.
PDL1,
So overall, this patient with this trial is not eligible for immunotherapy. So would you, Indranil, offer sacituzumab single agent or datotmPD, or would you go with immunotherapy?
No, as I said, if I have access to everything, I would prefer Dato-DXd considering the survival benefit and the doubling of OR, which is not seen with sacituzumab. But in practice, probably I would go with Vamshi and just give chemo plus Tori because that is easily available and doable.
Ghanshyam, what is your thoughts on this trial?
So definitely, so if SG is available, so I'll go for SG. Otherwise, yeah, so Story is not available, and so some people can afford that. So that is the choice.
So, Dr. Indranil, your thoughts on the response rates with this drug?
Yeah, that's what I said. The SG did not better chemo in terms of OR, and the PFS was also same. Only the DOR was better. The PFS was better, but that is because of the DOR, not the OR. And the OS data is still not mature. So far, it's only 21 months versus 20 months, something like that.
Yes,
So,
the overall survival data is not mature.
not
Vamshi,
mature.
your thoughts on this?
It is like I said, it's a decent drug, but the whole point is again you're trying to give something over chemo because you feel it will work. But I am happy to use it in the second line. I'm not pushing it in the first line.
Fair enough. I think Dr. Indranil has put this across. There is some improvement in median progression-free survival. The response rate seems to be the same, but it is more durable, and the overall survival data is immature. In SABC, they looked at the safety analysis and they looked at neutropenia. In fact, quite a few deaths, and all of that were when patients who did not receive GCSF prophylaxis. And so now there is a study wherein they tried to give GCSF and loperamide prophylaxis for this patient and found that the incidence seems to be reasonably less. Indranil, in your patient with sacituzumab govitecan, do you do all these things upfront, or you just dose reduce upfront?
no, GCSF we give always. Loperamide not upfront.
Dr. Ghanshyam?
So growth factor, yes. So loperamide, SOS.
Fair enough. So this is, I think, one of the highlights of these meetings, the Tropion Breast 02, which is Dato-DXd versus investigator's choice. So the trial seems to be reasonably similar to the Ascent 04. So if you look at it, the pre-selected chemotherapy drugs were a little interesting. Paclitaxel was there, single agent carboplatin, single agent capecitabine and eribulin. But you can see that the number of patients who received these drugs were very, very few. Most of them ended up with taxanes. Around 80% of patients received taxanes. So this is the PFS and overall survival data. Vamshi, your thoughts on this?
So the OS is, if you see there, 0.79. P-value is reasonably good. It is close to the boundary. 0.8, definitely you are a little hesitant. But then again, the question comes, would you want to keep it in the first line? What do you do later? And I'm coming back to the same thing. Are we having an overwhelming reason to put it in the first line? Look at the HER2. You have TDXD showing a huge advantage over the present drugs. This is not like that. So yes, as per data, you can offer it in the first line. We don't have Tropion, we don't have SG, so I'm happy to have this academic intellectual discussion. Monday morning, it doesn't really bother me. I'm not going to tell my patient, please import this drug from abroad because it is so good. So that's one way of looking at it.
Indranil, your thoughts are the same?
I think I already told that, yeah, actually, if there's a survival benefit as shown in this drug, you would need to think about it definitely. And the data of SG in second and third line is very good, but I don't know about Dato-DXd, how much it is in TNBC. Maybe for the HER2, the HR positive, HER2 negative, it is better, but triple negative, I am not so sure. So if there is a survival benefit, I would like to use it. The toxicity is definitely there, but I think it is more manageable than SG.
Fine. Dr. Ghanshyam?
Yeah, so datotoxicity toxicities are even lesser than the trastuzumab deruxtecan. If you see, the ILDs are much lesser than that. So though it shows some amount of stomatitis and dryness, so probably that was more outstanding. Otherwise, the ADCs, IDCs were much less. If you see the rates of grade, even the total population who received datotoxicity.
Yeah, so this was one of the main trials in both ESMO, as well as they gave some updates on the patient's quality of life in SABC.
Krishna, one thing, how many about this tropion 2 and the ascent? One important thing which I feel, and if I'm not wrong, is the post-progression access to ADCs in the control arm. And if I am not wrong, in Ascent, nearly everyone or a high percentage, near 90 or something, received a sacituzumab. And in TROP2, it would be less than 10, 15, if I'm not wrong. That data is very important, especially when Indran is speaking about the OS thing. And that is why most of the Ascent trials are negative for OS, because they mandate a sacituzumab on progression. So will that not affect the way we look at both the trials? And toxicity is better for tropion, that's no doubt about it. But I hope my point is getting across to the panelists. What do you have to say on the post-progression when one trial mandates and nearly everyone receives that drug? As Vamsi is telling, post-progression, there's a good drug, SG. And in one trial, no one receives or nearly very few receive it.
Vamshi, your thoughts?
Again, I agree with Sahu sir. It's just that you have to keep it in mind when you're talking, which is why many of these drugs don't have a head-to-head. You cannot say this is good or that is good. I don't have not used either of them. So if you ask me personally, which is the subset where I would go with the Dato, which is the subset I would go with the SG, I don't know. I don't know the answer.
Fair
Because the
enough.
PFS looks similar, the OS suddenly becomes severe in most of
Exactly.
these
If
cases.
on Monday morning you have both the drugs available in India, I don't know how to choose between the two. Very honestly.
Toxicity is worse with SG, that's for sure.
So it's easier to switch to SG in the trial also because SG is already a standard in the second line. But is Dato DHD? That's what I was asking.
Fair
Can
enough.
you mandate that you after progression you take Dato DHD and not any other chemotherapy?
So there is also a thought that if you start using these drugs, whether you can actually sequence them, because there are quite a few thought process that when you sequence them, it really does not have that much of good impact on the patients. In fact, the progression-free survival is not that great. It's as good as using any other chemotherapeutic drug. Of course, more studies are needed in that situation. So next, coming on to the BRCA positive patients, if somebody has got BRCA positive upfront, Dr. Gansham, what would your thoughts be?
So if there are no contraindication, then PARP inhibitors, olaparib, and we have access to that.
So upfront, somebody has been diagnosed with metastatic breast cancer, your drug of choice is a PARP inhibitor.
So I'll expose the patient to a platinum combination and we'll get some response, and then put this patient on a, because high volume disease we have used. So these patients, they don't respond and tolerate well. So you have a response with a platinum based treatment, and then put the patient on a maintenance sort of on a olaparib.
Dr. Indranil, what would your choice be? Would you go with the PARP inhibitor upfront, or would you say chemo first? Dr. Indranil? Dr. Vamshi, can you take it?
Yeah, I would be happy to use a PARP. That's what the data was. So that's what the trial did, and I'm happy to use it. It's logical and it seems to work.
So are you basing on
But
these two trials?
correct. So the only thing is, in this study, the survival wasn't seen. Final overall survival was not seen. But it's again an oral tablet, so it's okay to use it.
So both these trials are actually after prior treatment. So if somebody has been newly diagnosed and is BRCA positive, would you give them taxanes or platinum and then think about using this, or would
Chemo
you
and
want to
then
use it upfront?
some chemo and then this.
So you would not use this as the drug of choice, because
No,
In the
not as a drug
NCCN
of
guidelines, it is the drug of choice.
No.
CCN says a lot of things, so
Okay. Dr. Indranil, are you now available?
So it has to be a combination chemo then. So he's on a call probably, that's why.
Yeah, I think so. So basically, these trials were done actually in patients who have received chemotherapy upfront, and if you see the comparison, the comparator arms were not the standard taxanes and anthracyclines. So I think even though NCCN guidelines does tell it is the drug of choice, probably you would use, most of us probably would use chemotherapy first and then switch to PARP inhibitors. Vamshi, any thoughts?
no, I agree. That's what I'm also saying. Even though you would possibly want to use it upfront, that it's more that there's the thought and the hope that it works very well rather than actually evidence.
So would you do only BRCA 1 and 2 germline, or are you doing other things as well, like looking for PALB2 and somatic mutations?
We are doing only BRCA1 and 2. I'm not sure this whole HRR is something that works everywhere. I'm not sure HRD is something that works everywhere. I'm not aware of the data. I have to read more about it. I'm not aware of the data.
Indranil, your thoughts?
Yeah, what is the question?
So the question is, apart from germline BRCA 1 and 2, would you expand olaparib usage to other indications?
No. Only germline, BRCA.
Okay, Dr. Gansham?
So I think so there is a role for an HRR beyond ovaries. So ovaries has not shown the benefit beyond BRCA1 2, but in prostate and breast, even the PALB2 and in the RAD in the prostate, so they have shown a benefit. So
yeah, it seems to be that there is some good response in germline PALB2 and in somatic BRCA1 and 2. So probably we need to start at least testing these patients so that we have one option open. So this is the guidelines. I will not go into the details we have discussed. So there are few, 3-4 points which I thought is interesting. At least it's very interesting for me. So somebody with ER 4%, Dr. Vamshi. So this is a common problem we face. ER 4%, young patient. What do you do?
ER4, I would still treat it as a TNBC. 1 to 10, I'm kind of still pushing it out triple negative.
Okay, so would you use immunotherapy in this patient? You would treat them exactly
If
like
it
how
is
you would use.
PL1 positive, then yes.
Okay, Dr. Gansham?
yeah, so even in a neoadjuvant setting, such patients will be treated with immunotherapy.
Dr. Indranil, you would also do that?
Yeah. Agreed.
So interestingly, this was one of the papers presented, I think, in ESMO. So evolution of ER cutoff definition for clinical trials for TNBC. So what you can see is the percentage of TNBC trials allowing ER low has increased now up to 25% of trials done in triple negative breast cancer are including the ER low. So out of 621 clinical studies which they looked at, 24% of them did allow ER low. So I think somebody with a low ER, you will be thinking about using the standard treatment, what you would do in a triple negative breast cancer. Imagine you give them immunotherapy and with chemotherapy, Gansham, and after a few cycles of chemotherapy, you stop. At that point of time, you continue immunotherapy and add hormonal therapy, or you just not expose them to hormonal therapy.
So I have exposed them. So at least I remember quite a few patients who are on tamoxifen and they've been doing well. So,
Vamshi, you would also do that, probably an induction chemo with immuno and then switch to hormonal?
I wouldn't. If I was treating it as a HR positive, I might as well go the entire HR positive with the CDK inhibitor and all.
So interestingly, there are few trials and some studies suggest that even if they are ER low and you treat them as triple negative upfront, if they have not been exposed to hormonal therapy, their prognosis is worse compared to if you expose them to hormonal therapy at some point during their treatment. Indranil, your thoughts?
Yeah, I will agree with Vamshi that if it's ER positive, somewhat at least low or whatever, then we will do the full. If I have stopped chemotherapy, I will give the full therapy like AI with CDK4/6 inhibitor.
Fair enough. So there was one study in ESMO where they looked at circulating tumor DNA and found out that the level of circulating tumor DNA corresponds to the amount of disease and tends to pick up the recurrence or progression earlier than that. But I'm not sure whether it is going to be useful in clinical practice at present. Now, with the availability of all these things, what happens to our big baby? Dr. Vamshi, what do you do? Do you think about this big baby at some point of time in a TNBC?
Second line, yes, second or third line, not in the first line.
So how do you choose between, say, sacituzumab versus this?
HER2 2 plus fish negative is a place where I would possibly tend to use this more, but this would be probably after the sacituzumab. Do I have evidence for it? I don't know.
Dr. Gansham?
Since we are not, don't have neither dato-DXd or SG, so even with the low HER2, even with the ultra lows, I have used at least 2 or 3 patients with in R2 and with a mixed response, I can say.
Dr. Indranil, your thoughts?
Yeah, mostly we are using T-DXd only because that is easily available and the data is there.
So there was this paper this year itself where they compared trastuzumab deruxtecan with sacituzumab, large real world analysis. What they found is, just like Dr. Vamshi said, if the HER2 is low, then probably TDXT would be favored over SG. But if it is ultra low or HER2 0, then probably you should go with SG first. So this is some real world evidence, not a clinical trial.
The ultra low data is anyway with the HR positive. With the triple negative, we have the HER2 low data, not the ultra low.
Yeah, but this is what is
yeah, this is a real world. This is a real world.
In a real world.
Yeah.
Yeah. So the last point is on sequencing, which I already mentioned. It seems that giving chemotherapy between ADCs will give you the same result as sequencing 2 ADCs. So there may not be much point in at least sequencing 2 ADCs at the present moment, pending further data. So I think I will end there. Probably I will ask each of you for your any major change you have done in the last 1 year in TNBC metastatic. Dr. Vamshi?
I think the biggest change we have done is looking at HER2 and HER2 1 plus and 2 plus. I think that's the practically speaking change I have made. Other thing is whole enthusiasm. At least I thought that we could get away by using immuno later on, and there's no evidence for that. So immuno, if at all I have to use, I'll use in the first line. Otherwise, I'll not use it. Third thing, the whole enthusiasm for NGS is pretty low for me, because if you actually look at it, the number of drugs that you can actually use in a TNBC through your NGS is so limited. Though, we talk of NGS, we say you should do NGS, but practically it doesn't really give us anything. So
Dr.
it's still
Gansham?
a disease.
Yeah, thanks. Yeah. Dr. Gansham, your thoughts?
So in a constant setting, so sometimes androgen receptors also help you for 3 to 4 months using either enzalutamide or an abiraterone. So I think so, like an like an OMCT sort of, or an anti-androgen should be done for our patients who cannot afford any of these fancy drugs today.
Dr. Indranil, your take, what have you changed in the last 1 year?
Last 1 year, nothing has changed for me. All the change was before that. Last 1 year, I'm just looking at what is happening, but nothing is available yet.
Fair enough. Fair enough. Dr. Sahu, over to you for your final thoughts. And
thank you. No, it's okay. Thank you. Thank you, Krishna. I think Indranil summed it up nicely. So there are a lot of trials. Good data is coming up, but yeah, we are not sure what will change for Monday practice. So without wasting much time, we'll go to the last part of the 2 days online meeting, and we have the last one. Dr. Sandil, who is a senior consultant at Indo-American. He will be doing on trials that made you think twice and left you spinning. So it is the best of SABCS and ESMO 2025. Dr. Sandil.
Good evening, everybody. Thank you, Sahu, for that introduction. Nice panel, Krishna. I enjoyed it. As Tabu said, Indranil's comment was very appropriate. I'm sure you're going to say the same thing after my talk also.
Can I ask you one question
Yeah,
before you take on?
yeah.
So there was, before you joined, there was something on Tori,
I just
NTMUC.
joined. I agree with you, Sahu. I just, heard what you said about the number of patients at risk. Yes, the data is not as robust as what you would like it to be. You're right.
Second, would you do that 1 to 10%?
I wouldn't do that 1 to 10% because
Okay.
this is something that consistently all the Chinese IOs are showing. Wherever the Caucasian IOs have not worked, whether it's in PDL1 negative or the PDL1 low population, they seem to be consistently showing data. I'm a little wary about using it there, but a desperate patient, a desperate doctor, you do desperate things. So as part of that, maybe a rare occasion. But if I really believe in the science, I don't think there's good data.
You may start.
Thank you. So what I'll do is, as I had discussed with Sahu, I'll just go through 4 abstracts which I thought are important for us to be aware of. As I always do, I will go through the trials, and as we are discussing the study data, I will give you some of those things that will leave you a little spinning. But at the end of every study, what I will do is ask some questions that come to all of our minds and try to tell you what I think the answer to those questions are. So the first study I will review is the HER2 Climb 05, something that you have discussed threadbare an hour ago. So the HER2 Climb randomized patients in the maintenance phase after the Cleopatra regimen to tucatinib, trastuzumab, pertuzumab, or placebo, trastuzumab, pertuzumab. So you could take THP of 4 to 8 cycles. It's not like DB09 where you could take THP endlessly. If I remember right, there was a patient who took 52 cycles of chemotherapy. So here it was much more controlled compared to what they did in DB09. What you need to note here is about no or asymptomatic brain metastasis confirmed by an MRI at screening. So all patients had an MRI at screening, which to my mind is probably the first time we are seeing a HER2 positive study doing, because all other studies would do an MRI for patients who are symptomatic. But this, if I'm not mistaken, is the first study doing that. And if you have a non-progressive asymptomatic brain met, you were allowed to be enrolled on the study. So this is slightly different from what all of us would refer to as active brain metastasis. 12% of patients who had brain metastasis had a 9-weekly MRI. If you didn't have any baseline brain metastasis, you had a 6-monthly MRI. So remember that the monitoring was different. MRI brain for all patients at end of treatment was done. So this is something that you need to keep in mind. I'll come back to this data a little later, or this monitoring protocol a little later. 70% de novo. The response to trastuzumab, pertuzumab, taxane chemotherapy was as expected. 72% overall response rate with a 9% complete response. Half of all patients who were enrolled on the study were ER positive. But the same pathetic story continues. Whatever happened in DB09 continues. I would say it's a little less pathetic compared to DB09. Here, 44% compared to some 15 or 20% in DB09 got endocrine therapy. It's even sad that on the placebo arm, only 46% got endocrine therapy. So suboptimally treated patients. No crossover from placebo to tucatinib was allowed. So you are likely to see an overall survival benefit because you were not allowed to crossover. But you could also argue saying that in the community today, tucatinib is available in the second line. So if you didn't get it, not second line, you would get it in the third line. So it'll be interesting to wait and see what happens. The primary endpoint was investigator-assessed progression-free survival as per RECIST. Again, something first time I'm seeing CNS progression-free survival in the first line study. We know the HER2 climb in the later lines had CNS progression-free survival. Primary endpoint was positive 24 versus 16 months. Is the control arm performing as we would expect to? Remember that this is a post-induction study. So you should add about 6 months to this. So that will be roughly around 22 months. In the initial Cleopatra, it was about 18 months. So it's kind of matching with what you have seen earlier. Delta of 8.6 months, nice early separation. Curves continue to remain separated. All subgroups, irrespective of hormone receptor status, CNS metastasis, or response to trastuzumab, THP, benefited from maintenance tucatinib, trastuzumab, pertuzumab. The BICR PFS, as you're seeing more often in the more recent studies, the number remained the same for the placebo group, but the PFS number jumped to 28.9 from 24.9 in the BICR PFS. So that also showed that the delta was 12.9 months for the intent to treat compared to 8.6. But interestingly, the hazard ratio was the same. There's a strong trend to overall survival. The HR is 0.54. In fact, the upper limit of confidence interval is less than 1, but that P of 0.03 is not yet reaching statistical significance. So it'll be interesting to see how many patients would get post-progression tucatinib. I'm sure a lot will get, and then assess the overall survival at a later point in time. So this is the point I was trying to make earlier about hormone receptor negative and hormone receptor positive patients. You see that the delta for hormone receptor negative patients is 12.3 months compared to 6.9 months for hormone receptor positive. And like what all of you were discussing in the panel earlier, patina takes the cake here. So it's 44 versus 29, vastly superior compared to what you're getting with HER2 climb 05. But it seems to be a good intervention for patients who are hormone receptor negative. Should you do HER2 climb 05 or should you do DB09 if time permits? We'll probably discuss that later. So in the negative patients, I'll give it a thumbs up, thumbs down for hormone receptor positive patients. Remember, I mentioned to you about the way the CNS was monitored here. They're showing a very nice curve for CNS PFS. But when you're monitoring patients once every 6 months, and the monitoring is different for patients who started with brain mets compared to patients who didn't, I don't know what is the value of showing this Kaplan-Meier curve and CNS PFS. For me, it's a missed opportunity when you're talking about a TKI and you keep talking about TKI and brain penetration. You had an opportunity in the first line to follow up these patients, report clearly what the CNS PFS would have been, and also the CNS protective effect, which means if you don't have a brain met at diagnosis, is tucatinib delaying or preventing the occurrence of brain mets? I think it's just like in DB09, it's an opportunity that was lost. That could have made the difference in this set of patients who you're using tucatinib. Of course, there was a 4.2 month delta for CNS PFS, but again, it's underpowered. Very few patients. You can't really do a powering with about 12% of patients there. So I don't think I will give a lot of value to what you're seeing on the screen because of the way patients were monitored and the percentage of patients who started with brain metastasis. Tucatinib toxicity, 1 out of 6 discontinued for toxicity, 1 out of 3 needed dose reduction, 1 out of 2 needed interruption. Interestingly, in the placebo, 1 out of every 4 discontinued treatment. 1 in 10 needed a dose reduction. So sometimes even placebo can end up causing a side effect, needing dose interruption, reduction, and so on and so forth. So don't underestimate the adverse events with a placebo. So what are my thoughts? Are the results practice changing? Absolutely yes. Do all subgroups benefit? The answer is yes. Who should get tucatinib HP post THP? I think as of now, the HR negative subgroup. CNS protection unknown. CNS PFS looks better, but I don't think you can come to any major conclusions based on this. The toxicity is as expected. Do we have any biomarkers based on which we can choose HER2 climb 05? No. Does it answer the induction question, which is should you be using DB09 or should you be using THP? This study was not meant to answer that question, so we will only discuss it if time permits later. So for me, it's a thumbs up as far as practice is concerned. So the next study I will review is the lidERA study. The lidERA tried to ask a very simple question. Is giredestrant superior to standard endocrine therapy? Okay, it's a very simple question, looking at a valid endpoint and trying to answer that question. So these were patients with early breast cancer. Of course, we've spoken so many times about the risk of recurrence for these patients. One point I want you to note is that there were only 2% of patients who are in the ER low category. So does this result apply to the ER low category? You can always discuss and debate, but I would think yes, because if standard endocrine therapy had benefit in the ER low, I would expect giredestrant to also have a benefit in that population. Was the duration of hormone therapy specified? No. All that they said is at least a 5-year treatment duration is what you should be getting. In the giredestrant arm, everybody got an OFS. 40% were premenopausal, 16% were on tamoxifen. So that means these were premenopausal patients who did not get ovarian function suppression. The primary endpoint is a valid primary endpoint, which is IDFS. 21% node negative, 70% of patients or almost 80% of patients were node positive, 80% took chemo, because one of the ways of saying that it's a high risk population is that if the majority took chemotherapy. So if you kind of subcategorize the patients who went into the study, the majority were high risk. That means these were monarch E patients and some of these Natalie patients also. There were a set of patients with medium risk, which was about 30%, which belonged to the Natalie. Of course, in Natalie, you didn't have the T1C patients. In this trial, you had T1C patients who had a high oncotype DX and so on and so forth, who were also enrolled. This study was a positive study. The IDFS at 32 months follow-up was in favor of giredestrant compared to standard endocrine therapy. Now the question comes, is the standard of care standard in this study? So, there are many ways of explaining why patients didn't take CDK4/6 inhibitor. One is that when the study started enrolling in 2021, there wasn't a monarchy that showed a significant benefit that many of us thought was worth using that particular intervention. Of course, it got better with time and finally ended up in an overall survival benefit. That could have been one reason. The other is patients didn't really want to go on a drug which was toxic, giving you very little IDFS benefit. And then finally, you could just say these were a set of patients who the treating physician and the patient thought was not worth going on abemaciclib or Natalie, and hence took only standard of care endocrine therapy, which would have been either OFS plus an AI in postmenopausal women, or tamoxifen in premenopausal women. So you could debate that for hours together. Why is the standard of care different? But these are some of the points I thought would explain, at least in part, why the standard of care did not have a CDK4/6 inhibitor. 30% risk reduction, a p-value that is significant. You see that at the end of 24 months, the delta is 2.5. At the end of 36 months, it's 89 versus 92. That's roughly about 3%, okay? Now, let's ask this question. If those 16% of patients also had ovarian function suppression, would the benefit have been lesser? Maybe a tad lesser, but would that have been insignificant? Probably not. So even if you say the HR was around 0.75, we would still think that's a benefit, though the benefit is modest. Let's put this into perspective. Now, the 3-year IDFS in the control arm is very similar to what you get in the Natalie and monarchy. This was 89, 87 for Natalie, because this is a population that's kind of heterogeneous, more similar to Natalie than monarchy. Of course, monarchy is 83% at the end of 3 years. The HR's almost kind of matching 0.69, 0.75. The absolute benefit at 36 months for Natalie is 2.7, but everybody shows the discussion slides that were shown at SABCS. That is showing you monarchy at the end of 2 years, not 3 years. At the end of 2 years, it shows a 2.5% benefit. At the end of 3 years, it's a 5% absolute benefit, which is double of what you're getting with giredestrant at the same time point. Do we expect the curves to diverge? Yes, that's what it looks like. If you plot a trajectory, it looks like these curves will diverge over time and the benefit will improve. So, positive study, something that you can't ignore. What about medium risk patients? Likely to improve with time. At this point in time, it's 0.74. The confidence interval is wide, but as events accumulate in this group, something that's happening very similar to what you're seeing with Natalie. As time goes by, you will see that more and more patients will have events, and once you start having events, then you start getting a hazard ratio that becomes significant. And interestingly, in the Natalie, you're seeing that the hazard ratios are actually better for the node negative population than the node positive population. So we need to wait to see what happens in this study. So is this practice changing? Yes, for those who will take endocrine therapy only without the CDK4/6 inhibitor. Is there any reason to believe that the benefit will not increase over time? No, based on past experience, it will increase over time. What if the patient is eligible and can take an endocrine therapy plus CDK4/6 inhibitor? Certainly that would be the preferred standard of care. Can we conclude that an AI plus CDK4/6 inhibitor is equal to giredestrant? No, no, no. Giredestrant, already I showed you, is not as good as Abema plus a CDK4/6 plus an AI, because the delta that you're seeing in Abema trial at this point in time is double of what you're getting. So many times you kind of cross compare numbers erroneously and then try to draw some wrong conclusions saying that giredestrant may be as good. Giredestrant is unlikely to be as good as an AI plus a CDK4/6 inhibitor. Why did giredestrant succeed in a low ESR1 mutation setting? I don't think anybody knows the answer. God only knows. Biomarkers, none. Can you add a CDK4/6 inhibitor to giredestrant? Because that's very enticing, I would say. Because if you have somebody with an N3 lymph node, you've got giredestrant that's better than AI. Can you add a CDK4/6 to giredestrant? There is a trial that's ongoing. It's a sub-study. We'll wait for that results. At least we know that the toxicity data is not more than what you get with standard endocrine therapy. And even in the lidERA study, giredestrant was not more toxic than what an AI or tamoxifen was. Can you incorporate giredestrant into the present treatment paradigm? That means some people think that you can use AI plus a CDK4/6 in the first 2 or 3 years, and then after that get on to giredestrant. I would say speculation at this point in time. I'm not too sure that we should be doing something like that at this point in time. What are the other concerns? Duration of therapy. It's been left open. It says at least 5 years. What happens after 5 years? We just don't know. And of course, the financial toxicity of using a SERD is something that a lot of our patients may not be able to afford as and when the SERD comes in. So for me, it kind of is not fitting in the present paradigm of the way we would manage this disease. So it leaves me a little confused. That's why I'm spinning a little bit. Where do I fit in? But the simple way of looking at it is, if you had giredestrant available, if your patient was going to take only AI or tamoxifen, then instead of that, it might be worthwhile considering giredestrant. We continue to remain with giredestrant. Sahu wanted me to discuss the EVERA study. So what was the question that the EVERA study was asking? The question again was simple. Is giredestrant superior to standard of care endocrine therapy when combined with everolimus in patients progressing on endocrine therapy plus a CDK4/6 inhibitor? So everolimus is the same in both arms. Giredestrant versus standard of care endocrine therapy. So that standard of care could be exemestane, fulvestrant or tamoxifen. They continue treatment until progressive disease or unacceptable toxicity. This is very similar to the EMBER-3 study. There's no biomarker selection here. 75% of patients had a CDK4/6 more than 12 months. So to enter into the study, you should have had at least 6 months of a CDK4/6 inhibitor. So you're kind of teasing out the biologically better patients in this study, because the PIK3CA and all those bad biology patients usually have early progression within 6 to 9 months. So you're taking only patients who are beyond that 6-month point, and 3 out of 4 patients were beyond a year. So it's a set of patients who have good biology. Co-primary endpoints: investigator assessed PFS in those who had the ESR1 mutation and the intent to treat population. The co-primary endpoints were positive. The hazard ratios were very good. 0.38 in the ESR1 mutation population, 0.56. Of course, if you look at the numerics, 8.77 versus 5.4, 9.9 versus 5.45, looks better for the ESR1 mutated population. 10% of early progressors seem to be salvaged by giredestrant-based therapy rather than standard of care endocrine therapy. You see that at about 2 to 3 months, about 80% of patients in the standard of care arm progress, while that's lesser on the giredestrant arm. So there's a small percentage of patients who you can salvage when you're using a treatment like this. So how much of value that will really have is something that will depend upon multiple factors, including disease burden, when did this patient progress, is there an ESR1 mutation or not, and so on and so forth. This forest plot is a subgroup analysis of a subgroup. So it gives you some hypothesis. It does not tell you what to do. Clearly, like in all the previous studies, patients who have an ESR1 mutation seem to be benefiting from giredestrant much more than those patients who don't have an ESR1 mutation. Now, what is important to understand, and the data from the lidERA or the EVERA is saying, is that the overall response rate is better even for these patients in whom the ESR1 is not detected. So if you're looking for somebody in whom you are interested in responses, then that's an intervention that you might consider, but that's an endpoint that's very iffy. So I would say that the benefit is maximum for patients who have an ESR1 mutation. This is PFS by PIK3CA AKT PTEN alteration status. So even if you had those alterations, again, just like something that you saw in the EMBER study, if you have somebody with an ESR1 mutation plus one of these mutations, it benefited. Whether you had ESR1 only, it benefited. If you had a PIK3 AKT PTEN, it benefited. So we kind of moving back and forth between these biologically selected versus the biologically unselected patient. What about PFS based on prior duration of CDK4/6 inhibitor? While I said that it's a biologically selected set of patients, this forest plot actually did not prove what I said. Whether you're less than 12 months, you're 12 to 24 or more than 24, the benefit actually did not seem to be different. While it's very hypothesizing to think that if you had a longer run on a CDK4/6, you will have a longer run on this intervention also. This forest plot actually does not say so. Now, this is a slide that's been shown so many times. This is to show you the multiple interventions that are available in this setting. I'm not going to go through each of these interventions. A few points that I want to make here. These are cross comparisons, different lines, different biomarker subsets, different patient populations. So interpret with caution. Salient points. If you look at benefit magnitude, the benefit magnitude is least with fulvestrant, better with SERD in an ESR1 mutant compared to fulvestrant. It's better for fulvestrant plus a targeted therapy in a patient set who has a PIK3C AKT PTEN, and that benefit also seems to be very similar to what you get in the fulvestrant plus a CDK4/6 inhibitor. I'm talking about EMBER-3 here. The benefit seems to be maximum. For a SERD plus the CDK4/6, and that's EMBER. I'm sorry, the fulvestrant plus CDK4/6 inhibitor, where those, the post-MONARCH study and the CDK4/6 inhibitor continuation studies that we have, both the abemaciclib and ribociclib studies. So fulvestrant plus targeted therapy seems to be equivalent to these interventions. A SERD plus a CDK4/6 inhibitor seems to be as good as giredestrant plus everolimus, the Evera, and also fulvestrant, gedatolisib plus a CDK4/6 inhibitor, which is palbociclib. So it's just a general idea based on the numbers that we are getting in these studies. But the other important point is the better outcomes are there in earlier lines, ESR1 mutant population, and longer CDK4/6 inhibitor exposure. Where am I getting this longer CDK4/6 exposure? This is from the EMERALD study. Patients who had an ESR1 mutation and a CDK4/6 exposure of more than 12 months had a PFS of 8.8 months with just the SERD. So you have to kind of put in so many things, consider so many things when you're making decisions in this set. I don't have a standard formula that you can use in this set of patients. Of course, as all of you discussed in the earlier panels, we don't have most of these drugs, so life seems to be simple, but at some point in time, it's going to become more and more complicated. Where does Serena kind of fit into this paradigm that we are discussing here? Serena is where you do ESR1 mutations and preemptively change your drug to a SERD, which is camizestrant, instead of changing to camizestrant plus minus a CDK4/6 inhibitor at progression. So these are some broad thoughts rather than going into the specifics of each of these studies. So what are my thoughts on this study? Do we need another option in this already crowded space? Why not? More the merrier. Is Evera an option in the post CDK4/6 space? Yes, the trial is positive. Who benefits more? The ESR1 mutant patients. The intent to treat, there is a benefit, but the benefit seems to be very little for the ESR wild type. Is the benefit biomarker independent? Yes. When I say biomarker, I'm talking about PIK3CA, PTEN, AKT, and so on and so forth. The AE profile is comparable to the other options. Should we continue to do molecular biomarkers? We said EMBER-3 works in all populations. Evera works in all populations. So why should you waste your time and energy on sending an NGS and getting that PIK3CA, PTEN, AKT? I think we should continue to do this. The reason we should continue to do this is, I showed you even in the Evera that the magnitude of benefit changes the moment you have a particular biomarker. If you have an ESR1, the magnitude of benefit is more. So it's like saying in a HER2 ultra low versus a HER2 low, is there a difference in the magnitude of benefit? All of us would agree that the answer is yes. Should we just do it in all patients without knowing this information? The answer is no. So the same analogy applies here. You do your biomarkers because that's going to help you decide what the magnitude of benefit is, and then use this particular intervention. And then, the approvals are based on some of these biomarkers. EMBER-3 is approved only for patients who have ESR1 mutant, though there was benefit in the ESR1 wild type population also. This is what I was saying. So how do we choose? Disease, data, drugs, dollars, desperation. You use all of these factors in order to decide what to do. So it kind of leaves me more confused, and I'm sure all of you who are listening are also more confused. Lesser drugs, more comfortable is our decision-making process. The more drugs and access to biomarkers are there, the more complicated this decision is. So we come to the last one. DB11, what was the question that was being asked? It was a simple question. In the neoadjuvant setting, is TDXT more active than dose-dense AC? Because the rest of the neoadjuvant therapy was similar. So simply, can TDXT be a substitute for the anthracycline that all of us continue to use, at least in some patients? Very important is the fact that TDXT arm alone closed because the PCRs were only about 47%. They thought they would compromise surgery, compromise outcomes, and that arm is not likely to end up positive, so they closed it. Now, for me, this rings a bell because all of us are wanting to see what happens in the TDXT alone arm of the DB09. It ended up being a cropper in DB11. It'll be interesting to see what happens in the DB09 study. So there was some protocol mandated treatment, but it was not strictly mandated. So if you had a PCR to whatever therapy was done, you could then continue your HP like what we would all do. But if you get a non-PCR, then you do TDM1 for up to 14 cycles. Now you can question what's the benefit of TDM1 after no PCR with TDXT, open to speculation and discussion. Again, how many patients received endocrine therapy? We just really don't know. Interestingly, 10% of patients who did not get a PCR on the TDXT arm had chemotherapy, and I assume that it's anthracycline-based chemotherapy. So desperation, 10% ended up getting anthracycline. Again, one of the other firsts, if you may call so, in a phase 3 study, in a phase 3 randomized study, you're seeing PCR as the primary endpoint. Again, I can't think of another study that was phase 3 and had PCR as the primary endpoint. You can have PCR as a co-primary endpoint, and the study that immediately comes to my mind is the Niagara study. PCR and EFS. Here you have only PCR, and the EFS was a secondary endpoint and it was not powered. Okay. So the population was truly a high risk population, something that you would routinely not see in the Western world. In fact, interestingly, when Dr. Nadia Harbeck was asked, how would you apply this? She said, I don't see a patient generally that gets, who would fit into DB11 study, although I was the PI on the DB11 study. They have a screen detected set of patients, so they're very small lumps. Anyway, having said that, the primary endpoint was positive, 11.2% difference. TDXT followed by THP, 67% versus 56. The delta in HR positive was 9%. The delta in HR negative was 16%. EFS is kind of widening of the curve, but don't get carried away because the way the y-axis has been represented here, see that it's 0.8. That's where the y-axis is starting to 1. It makes you look like as if it's going to end up in an EFS very soon. If you see the actual one that's there in the primary in the article that's I think it's in the ESMO Open or one of those Annals of Oncology, I'm sorry. If you see that, that's a nice representation how that EFS curve is actually there. So this is an exaggerated EFS curve. So don't get carried away by the space in between the two curves. There's hardly any space between the two curves in the properly constructed Kaplan-Meier curve. I want you to compare this number. The 3-year IDFS in the DB05 arm, that means the non-PCR arm which took TDXD, is 92%. And that's at 3 years. At 2 years, in this you have an EFS of 96%. So if you say that in the next 1 year, about 2-3% of patients are likely to progress, that's not going to be very different from what the 3-year IDFS in DB05 is. HR of 0.47, HR of 0.56. Of course, this is unlikely to end up with statistical significance because it's not powered, and the study is going to end at 10% events. Is this practice changing? Certainly not based on PCR. Is the PCR rate likely to be significantly higher compared to TCHP? Now remember that here you did AC, dose dense, followed by a taxane, trastuzumab, pertuzumab. Now, is the PCR rate likely to be significantly higher than TCHP? I would say less likely. Why am I saying less likely? Because if you cross-compare studies, anthracycline versus non-anthracycline, TCHP seems to be having a slightly higher PCRs compared to the anthracycline-containing studies. So here you have a delta of about 11%. That delta is likely to come down by 3-4%. So you're ending up with 7-8% difference. I don't know whether that's really significant. In my mind, it's probably not. So I think this probably was a very important question to ask, which was not asked in the discussion. But for me, the more important question is, what does history say about the way we change practice? Our threshold to change practice is very low. and it's very low when you're escalating. Remember Neosphere and Trifina were the studies based on which we changed from trastuzumab to trastuzumab pertuzumab. Both of these studies were phase 2 studies. In fact, in Trifina, the primary endpoint was cardiac dysfunction. In the Neosphere, the primary endpoint was PCR. The event-free survival was numerically better for dual anti-HER2 therapy, but not statistically significant. And we changed practice. FDA approved. NCCN said go ahead and use dual anti-HER2 therapy just based on PCR. All of us changed, right? I took a long time to change, but ultimately I was forced to change because the community, I had to change. Let's not get into the specifics of that. For me, the question that most people are breaking their head over is the anthracycline question worth wasting time on? I don't think it's, worth wasting any time on. Should the standard arm in the study have been TCHP? I don't think we should be wasting time on anthracycline or not. I think there are strong believers, there are non-believers. That's about it. Use whatever you want to do. Make sure that you're using your anti-HER2 therapy. For me, that's very important. Is this delta in PCR likely to result in an EFS that's significant? I'm not too sure. The numbers are not robust enough, they're not big enough, and it's not powered for EFS, so I doubt that it'll end up showing a positivity. Now, if you find that the EFS is positive hook or crook, will this be practice changing? Maybe for the anthracycline people, but not for the TCHP people, because of point number 2 that I tried to address during this question and answer slide. What strategy in non-PCR post-TDXT is optimal? Should it be TDM1, trastuzumab based, or something else? Better EFS if all non-PCR had gotten TDM1. Remember that on this study, only about 50% of patients who had not had a PCR actually got TDM1. So if everybody got TDM1, would we have done better for the intent to treat? I just don't know the answer. Would DB05 be a better strategy? That means you give TCHP for everybody and then escalate to TDXT in non-PCR. For me, at this point in time, maybe, because of the EFS that I cross-compared and showed that is not very difficult from what not very different from what you're getting from DB11, and just over a third will need escalation compared to everybody getting it. But having said that, you only get 4 cycles of TDXT, less toxic, shorter, compared to 14 cycles of TDXT if you're following an escalation strategy. So I don't think there's a good answer at this point in time. What is disappointing? It's the TDXT arm. All of us would love to see an arm where, or a point in time in treatment where you are not using chemotherapy at all. But I think for all of us, we need to wait for a long, long time to come before we say we can give up chemotherapy completely. What's the future? We just don't know, but it seems to be an adaptive strategy where you might probably using HER2-DX, imaging, ctDNA, etc., etc. Was AZ smart in powering the study for PCR only and not for EFS? I said PCR first time in a phase 3 study. Most of us would think that it's a missed opportunity. You should have powered it for EFS, shown that the EFS is better, and then made this standard of care. So that's the reason I'm asking this question. Was AZ smart in powering the study for PCR only and not for EFS? Absolutely and absolutely. They were extremely smart in doing this. And I go back to point number 3 that you're seeing in this slide. What does history say? And history repeats itself, but in such cunning disguise that we never detect the resemblance until the damage is done. So that's what my concluding remark on this particular study is. Thanks so much, Sahu. And if there are any questions,
Which you
anything
told,
that you want to
HER2
discuss.
climb, HER2 negative in ER negative versus DB9.
Okay.
The PFS still looks very shorter than DB9.
Correct. So if you're going to use DB9, so there are 2 ways of approaching. There is a school of thought which says that you use DB9 for a period of time and then shift to HER2 climb. I don't think that story is a story that is likely to be right in real world practice, because you don't have carryover effect for DB09. So if you're stopping DB09 early and then transitioning to some other treatment, your PFS is definitely likely to be low. So I wouldn't think of doing that at this point in time. Now, visceral disease, we said, I saw Rajiv showing some slides saying visceral disease, I want to do DB09. So let's look at the response rates. The response rates in DB9 is 6% or 7% better compared to what you get with Cleopatra. So disease burden and visceral disease with a 6% difference in the response rate, though the CR rate is 6 versus 12 or some 15%, something like that, I don't think it's a great intervention to use just because you have large tumor burden, because the response rates don't really reflect that. CNS disease, again, you guys really, spoke about it. Can you just give radiation and do Cleopatra? I think that's a reasonably good strategy. I also think DB09 is a wasted study where you should have looked at CNS failure, CNS PFS. That would have pushed that up in that CNS, disease strategy. Suppose you want to use a strategy wherein you're not doing radiation therapy, you don't want to do radiation therapy, then in brain mets, that might be a good strategy. But HER2CLIMB also had a small percentage of patients who had asymptomatic brain mets. So again, comparable. PIK3CA, it's a post hoc subgroup analysis. I don't know whether it's really going to stand the test of time. So at this point in time for me, I really don't know where the DB09 fits. It's a short period, HER2CLIMB, 3 months of chemotherapy is not very difficult unless your patient is very hell-bent upon saying, no doctor, I don't want chemotherapy. And who says, TDXD is not chemotherapy? It is chemotherapy in a camouflaged version. So for me, I don't really see a great reason for DB09 unless you say that it's showing overall survival benefit and so on and so forth, then we can revisit. So I'm not very impressed with DB09. I've not changed my opinion in 6 months.
Thank you. I think we will stop, and it is already 9:40. Thank you, Sendil sir. You always have done the things very nicely, and thank you all the faculty, all the moderators, all the panelists, and I cannot thank less Tarun and his team, and Daud, especially, who has been the man behind this one. Thank you all, and hope we meet after ASCO and do a deep dive into what has happened in breast cancer. And thank you, everyone. Have a good dinner, a lovely dinner. Those who have not had a dinner till now, then sleep well and be fresh for your OPDs tomorrow. Bye.
Thank you. Bye-bye.
And we will have this recordings put up in the things and all links, and no request personal to be done to me. We will send it in the whole group so that everyone can enjoy the 2 days.
Sure.
Okay, thank you.
I'll take care, sir. Thank you. Thank you, Dr. Sao, sir, for giving this opportunity. And so on behalf of all my colleagues, Gidika, Dao, Aditya, everyone, so thank you so much for this. And till we meet again for this fantastic academic experience. Thank you. Good night. Stay safe, stay blessed till we meet.